Good afternoon, everyone. Good afternoon. If I can get everyone to take their seats, we'll be starting in less than 30 seconds.
Ooh, 30 seconds.
Yeah. All right. All right.
How do you turn off the mic?
I don't know.
Please take your seats. Thank you very much.
That's good.
So I hope everyone enjoyed the lunch and that there was a decent enough selection of random little, like, tea and crumpet related sandwiches. I don't know. There was like a crab thing, which was simulated crab, but I guess it's better than like nothing. So, you know. Anyway, so welcome back, everyone. Good afternoon. Thank you for staying with us. So we have a really great panel next, and it will be led by Rania El-Mujamar, and the panel discussion is focused on tools to produce a culturally safe environment in maternal health care. Rania is a published writer whose work explores themes of identity, womanhood, blackness, flight, exile, migration, belonging, gender, sexuality, and beyond. She is also an experienced anti-oppression, equity, inclusion, and anti-oppression educator and consultant. So Rania's going to take it over from here. She'll also introduce our panelists. Each panelist will say a little brief blurb about themselves, and we'll then conclude after the panelists speak with a little bit of a Q&A. Thank you.
Thank you so much for that introduction. I'm really grateful to be here today and to share space with so many remarkable people and to have some challenging but productive conversations. As I was so beautifully introed, I work in anti-oppression, liberation, and equity consulting, primarily in contemporary arts institutions, but also at the intersection of racialized maternal health and technology. So I'm really excited to be here today. I'm going to give the panelists the opportunity to introduce themselves quickly, and then we'll get right into it. Yeah? Do you want to start? Sure.
Hello, everyone. I'm Roxana Sultan, the Executive Director for the Provincial Council for Maternal and Child Health, or PCMCH. For those of you who aren't familiar with PCMCH, we are a ministry-funded agency based out of the Hospital for Sick Children here in Toronto, and we have a provincial mandate to generate information to support the evolving needs of maternal child health care system services in Ontario. We are a resource to the maternal child health care system and provide system improvement support and determine the how services should be delivered across all levels of care in the province. So I'm delighted to be here today to speak about maternal health services. Thank you.
My name is Mani Vihanda. I'm a midwife. Is this too loud? No. I'm a midwife in Toronto and an associate professor at Ryerson in the Department of Midwifery. My area of clinical specialty and also advocacy and social justice and work has been in particular around working with people who don't have health insurance. So new immigrants, failed refugee claimants. There's many more categories of people who are falling into the uninsured box as we're having more immigration changes and the age of terror, as we're calling it. So yeah, my area is really around people who are highly marginalized and have many barriers accessing our healthcare system, and innovations in trying to develop pathways for them to get care, including an uninsured clinic partnership where everyone who comes to this uninsured clinic is seen by a midwife and primarily hooked up with midwives if they're low risk and obstetricians if they're higher risk.
Sorry. Hello, good afternoon. My name is Dr. Anya Noram. I'm a family doctor and public health specialist. I wear a number of different hats, but mainly my portfolio is around Black health, racialized health, and looking at systemic racism as a social determinant of health, as well as some work around chronic disease prevention, but also looking at that from the racialized and immigrant health lens. So I work as a program director at the Dalla Lana School of Public Health. I'm the Black Health faculty theme lead for the Faculty of Medicine at the University of Toronto. So I teach medical students about Black health issues. I work for Cancer Care Ontario as a regional lead, covering in particular the region of Scarborough, so giving family doctors advice on how best to help their patients with regards to the cancer journey, including screening and engaging immigrant and racialized populations on screening. And I also work as a clinician at Taibu Community Health Centre, which has a mandate to serve the Black community in the Greater Toronto Area. I actually don't see clinically pregnant women at this time, but again, a lot of my work kind of focuses on how racism affects our health as a community. And then the other hat I wear is I'm the Vice President of the Black Physicians Association of Ontario.
I am Dr. Placide Rubabaza, and I am an obstetrician and gynecologist with a special interest in minimally invasive surgeries. I practice at Ajax Pickering Hospital, which is part of Lakeridge Health. Another interest I have is certainly to work with the disadvantaged populations, particularly Black populations. I'm currently the president of the Black Physicians Association of Ontario. I work with Onye on some of these issues. And in terms of disadvantaged mothers, I certainly provide sometimes pro bono services on a case-by-case basis. I do work with midwives if need be in those circumstances. And the other thing I guess I do, I am the Vice President of the Medical Staff Association and therefore sit on the board of directors for the Lakeridge Health.
It's kind of hard to follow two doctors and other amazing panelists, but my name is Tanya Hales, and I am the founder of Black Moms Connection. It is an online global village of over 10,000 moms around the world, and it's also a local nonprofit where we provide workshops and events to educate and empower the Black women in the Black family.
Thank you, everybody. It's always really nice to hear people share a little bit about themselves, and it makes you feel like, gives you imposter syndrome sitting up here with people like this. But
Just thinking the same thing.
right? Shared feelings. So we have a few questions that we're going to get through, and then we're going to do our best to address most of the bulk of the questions, but I want to make sure that we also get the opportunity for participants here to come up to the microphone and ask questions during the Q&A. So the first question that we have is actually something that I have a lot of lived experience with as a Black mother, but also as a Black queer Muslim woman who's living in the inner city. So a lot of different intersections that really determined my experience with pregnancy and childbirth, and nothing quite like being a pregnant Black woman on public transit to really show you what anti-Black racism looks like in this city. But the question that I have for our panelists today, and I think what we'll do with this question is we'll start on the very end with Tanya, and then we'll make our way down, and then we'll keep going one person over every time, so everybody gets a chance to go first. So the question is, what are some of the greatest challenges Black parents encounter when accessing care during pregnancy and postpartum?
That's a great question. To start, what's great for me is, so Black Moms Connection started as a Facebook group for myself, being a Black single parent. Asked 20 of my friends to join me, and it kind of grew out of nowhere. And so we do have a lot of different conversations about care, about whether it's prenatal, during the pregnancy, postnatal care. And we do have, while it's centered in the GTA, we have maybe about 40% of our members are in the US, so we have a lot of different types of conversations, of course, because the care here in Canada is drastically different than it is south of the border. I think one of the biggest challenges is finding their voice in making sure that they can speak for themselves. So I look to that recent article with Serena Williams, how she just gave birth to her daughter. She's like, hey, I have, some technical medical term. And the nurses were like, you're drugged up, you don't know. And that's Serena Williams, right? Like, she's an Olympian, she's a world-class athlete. If someone knows their body, you would think it's someone who, plays sports for a living, and yet still, it was such a key example to how we don't always get the right to advocate for our own bodies. And it's hard, right? Like, they're doctors, they're supposed to know best. And so I think that's probably one of the biggest challenges that, I've seen in the discussions that we have in the group.
Thank you.
For me, I think this question is very, very complex. There are multiple issues that can raise this question. First of all, what I think is the most important is the question of access. And sometimes what I see is women immigrants who are here for sometimes a short period of time, and they do not have coverage or hip coverage. So who's going to look after these women? The second issue I see is the issue actually of young maternal age. And support in the community. So some of the people I see, they are very young, sometimes not educated, and I don't have the statistics to know really what is their teenage pregnancy in the black population versus the rest of the Canadian population. Maybe I should have looked that up, but that is something I thought. Sorry?
You won't find it.
Exactly, we won't find that because we don't really have racialized data. I guess we can come back to that later. Third issue, I think you spoke to that a little bit, is the. I think the. Are we considering this? I don't. Okay,
I think
no.
they're paging someone.
Okay, all right. So certainly the third issue is the issue of stigma, and I guess which sometimes goes with the social determinants of health. So somebody will present to the hospital, and they will be regarded in certain ways because of the color, or because of the sometimes they wait, or are they clean, are they not clean. So nurses, you can hear as a doctor, I work with nurses, and I can tell you that I think at my hospital we are very open, and we do certainly a great job at being very inclusive. But you may see here one comment or there that is stigmatizing that patient. Then the fourth issue, I think, certainly in most of the time in the postpartum period, is the issue of mental health. Sometimes with no appropriate support, issues of maybe postpartum anxiety, if not maybe depression, those issues do arise, and they become very problematic. So I think I would leave it there for now.
Yeah, so I think actually you covered it quite well from the, partum to postpartum period. I think when it comes to access to care, I have more of a recommendation than the challenge, and I think really one of some of the resources that we have here in Toronto that I just want to highlight are community health centers, because they are centers that do provide or have a budget for undocumented persons, or providing care for undocumented persons. It doesn't cover like the hospital piece around the delivery, but at least the prematernal pieces, or the maternal follow-up, and also the follow-up after from a primary care perspective. So those are centers like where I work, Taibu Community Health Center. Here downtown, there's a Women's Health and Women's Hands for women of color. There's also Black Creek CHC. So I encourage you to kind of Google community health centers if that's a place that you think you want to go, or refer your patients or your clients, because that's where there's that kind of comprehensive especially at Black Creek CHC, Taboo, and Women's Health and Women's Hands, culturally safe care that goes beyond just the clinical lens, but all the other things that you need to think about as far as wellness. Thank you. So yeah, shout out to those centers. And just since I have the mic for a moment, part of myself that I forgot to let you know about is that I'm a mother, so I have a 2-year-old and an 8-month-old, and actually on the bus I realized, because everybody is on their phone, if you just go up to young people and just tap them because they're busy, and you point to your belly, they get up.
I will keep that.
I'm half Nigerian, half Trini. I'm not shy. Get up.
I'll keep it in mind.
Maybe if you do it, they'll get up.
If I get reckless and decide to have another kid, I will keep that note in my mind.
I think this question has been answered really well. I would, I really look at it like we're dealing with a healthcare system and a political system that historically there's still a lot of colonialism and systemic racism built into our system, and we're trying to fix that instead of actually how do we create systems that are more equitable. And so I think that's a big issue. In terms of the actual barriers to clients themselves, I agree with a lot of what's been said. I think we also have to look at, really there are barriers, I would say, at every single level, from the lack of research on what the particular health needs are of Black communities, and also just lumping Black communities together. It's, genetically the most diverse group of people on the planet, the oldest group of people on the planet. And so I also think we have to recognize that there are very different microaggressions that people face. And unfortunately, I would say at the point of care, which is a lot of what I deal with, in terms of in labor, which is a highly vulnerable time and empowered time for a lot of people, the level of microaggressions that still exist within our healthcare system are really upsetting. But they're going to be very different from someone who has had genital cutting and the kind of comments they're going to have to, and I'm stereotyping here, but to the single younger woman from the Caribbean who lacks health insurance. And so, but I think part of that is because those microaggressions are different, that there is not as much of a holistic approach from a community level. So I think community health centers are amazing. And I have many partnerships with community health centers. One of the big gaps, I would say, is community health centers, very few, if any, provide intrapartum care. So almost everybody is referred out to an obstetrician, which is great. The costs of that are covered. But then you're also not necessarily working with people who've had training around holistic care and healthcare. And really that client is on their own until the 6-week postpartum mark. And so really, for us being involved in that level, there are many barriers, from not having a primary caregiver to not being able to get into a community health center because they're closed, to not knowing that midwives exist. And so, I think we have a lot of work to do.
Thank you, Roxanne.
I think, writ large at the PCMCH level, we certainly try to address the competence of clinicians to provide the services that they do in a way that is respectful and supportive, and recognizes the cultural diversity of the patients that they see. So I think there is really an opportunity for us to build out that competence, and it is certainly something that has been identified as a challenge currently. And as well, when we think about it from the patient education perspective, there is an opportunity as well to do a much more culturally and targeted, sensitive approach to patient education. And I think in the past we've had a bit of a broad stroke when it comes to both provider and patient education and competence building around maternal and neonatal services. So, certainly I think the challenges that we see see reflected back in the system today are an indication of the lack of that type of culturally appropriate training and competence building. So, you know, when I think about specifically some of the initiatives that we at PCMCH have initiated over the past couple of years, there has been a focus very recently in a partnered initiative with Health Quality Ontario and the Pregnancy and Infant Loss Network based out of Sunnybrook Hospital to provide competence for service providers in emergency departments who are providing care for patients experiencing an early pregnancy loss. And as we were going through our discussions with the service providers as well as with the patients, it became quite clear that there had really been simply a lack of education for service providers in how to address these types of situations in a sensitive way that recognizes that different cultures and different groups experience these things very differently, and that there is an opportunity to really target how you provide that support. And so I think as we move into further work on our end, we certainly are trying to build that lens into what we do, and to as well recognize that when we do have the voice of patients at the table, it needs to be reflective of the diversity of patients, not just taking one or two patients as a representative sample. So we're trying to certainly do a better job of that, and our hope is that as we get more and more equipped to manage how we do that competence training, we will be able to address some of these challenges that exist currently.
Thank you. I think there's a lot of this that I can relate to on a personal level, and a lot of it that I can relate to from a professional place. But something that I always advocate for is data, knowledge production, and that looks both at quantitative and qualitative data, and the believability of, you know, Black people who can have children or who choose to have children, and their partners and the communities that support them, looking at, you know, anecdotal evidence and personal narratives as valid ways of collecting and gathering information and sharing it. I think that's really critical. And speaking to the microaggressions piece, I think what's really important to remember about that is that you're not only experiencing them in the healthcare system. When you are a Black person who is pregnant, that is happening to you, you're a Black person period, but particularly when you're pregnant, that's happening to you from the time you wake up until the time you go to bed, and then you go into a space where you're supposed to be receiving care, and that becomes further amplified. And there's, you know, studies and studies and studies on the effects of racial microaggressions on mental health, and then that is amplified by the fact that you're, you know, creating a human being and about to have a child potentially. That becomes really further challenging, and I think we need to approach that in a really intersectional way, to really acknowledge that Black communities are really diverse, and there's a multitude of Blackness, and all our Black experiences are not the same. Looking at things like, you know, in my experience, it was everything from, is the father still in the picture? And I'm like, could you check off whether that was anti-Black racism, classism, transphobia, homophobia, or all of the above? That became really, and I stopped wearing my wedding ring because obviously your fingers get swollen and everything is irritating, you know? So, and that became a point of conversation that people would have, and, you know, both Black women and Black trans men and non-binary Black people who can become pregnant report experiences of, you know, I myself and another pregnant person are on public transit, and someone will get up for the other pregnant person who's not Black, and no one will get up for me. So you're being met with that kind of like microaggression violence over and over and over again. And then when you know, your healthcare provider, that's a point of contact and should be a refuge and a safe place for you, but often that's not the case. And the support is not as intersectional, it's not as interconnected and well-rounded and holistic in terms of taking into account, you know, really practical things that you might need, as well as things that are related to your physical health, as well as things that are related to your mental health. So those things seem kind of painfully absent, and it's well documented in terms of everything from the believability of Black patients to whether or not you get prescribed pain medication that you need. So a lot of that data is still there, but it's not really being made available in public and accessible ways. And I think there's a role for healthcare advocates to play here, in terms of both patient education and in terms of when you just can't do it anymore, someone to step in and to be able to advocate for you in that way. Yeah, I feel like that was my little rant that I added there. I'm going to invite anyone else who has any final reflections on this question before we move on. Yeah? Okay. So our next question that is actually something that I'm really looking forward to, because I know a lot of us are looking for like tangible things to take out of this space, is looking at some of the strength that exists in the community currently that can be leveraged to improve the experience of Black women, but I will actually expand this to Black women, Black trans men, and non-binary folk who can have children, accessing perinatal care. Yes, you're gonna go first this time.
Oh,
Yeah.
okay. I guess I'm starting first. I think the first strength that I can see can be drawn from the Taibu Community Center. I think the Taibu Community Center is located in Scarborough, and it was established to primarily serve Black communities, or the Black population of Greater Toronto. And again, I may lack on data here, but when I see what happens there, how services are provided, how welcoming that center is to disadvantaged population around that community health center. I think we at the Black Physicians Association sometimes think that we should have a second center, and maybe in the west part of the city. So I think that would be a great thing to have. So, and I think there are some discussions that are happening around that. So that would certainly be a great thing to happen. A second strength I see, or I think that we can, or we are trying to draw on, is the experience of, in case of physicians, Black physicians that exist in the community. Certainly at the BPAO, we are trying to advocate for increased numbers of Black doctors. When you look at the population of Toronto, for instance, you would see that around 10% of the population is Black. Yet when you look at the medical community, I don't think we make even 1%. Of the medical community. So those are some of the areas we are working in, and I can tell you that education is very important. Certainly the not everyone is really educated on different cultures, and if you are in a class of, let's say, in my situation, I was the only Black student in my medical class of 150. In some of the discussions, Black health was never discussed. But because I'm there, I can probably start to say, hey, did we think in problems-based learning, I could say, hey, did you consider this perspective? And the other person actually is not really at fault, because they may not simply think of, about that. But to have a diverse medical community is very important in addressing these issues. So I think the piece that I think we are working on in collaboration with at the current time with the University of Toronto, but hopefully very soon with the other universities, is to increase the diversity in medical schools. I think I'll let, I don't know which way we're going, but...
We're going this way?
Yeah, yep.
Oh, okay.
Okay, I think there are certainly many other things to be said, but I'll let Anya carry on from here.
Okay. No, I think, certainly I mentioned it in the previous cycle that, I mentioned the community health centers from a medical perspective, but also I think, so when the question is that's currently happening, and so as far as what currently exists, so that's kind of the extent of my knowledge, and I won't add to what Placide said, but I also just want to give credit. Part of the strengths that we need to look towards is, young students like Elsie who are organized today, right? And everybody who's in this room today who's, advocating in their own way for things to improve. So yes, that might not be where we currently are, but that is kind of, this is a window into where we will be and where our children will be. So I actually just want to give, let's just give a round of of applause to the organizers and to Alfie, right? And to the Mommy Monitor app, but this is the beginning of, more of our collective voices coming together. So I think that's at least promising, soon to come.
I have to acknowledge, as many of you might have guessed, I'm not a Black woman. I'm a racialized woman, but I'm always careful of speaking about other people's racialized experiences when that is not my experience. Although I do have a fair amount of experience working with really marginalized populations, and many of them are, I would say, it's interesting to see how our immigration system works. I work with a lot of people who don't have health insurance from the Caribbean and Latin America, and then many new immigrants from the Africas. And I actually think there are a lot of strengths, but that are not necessarily utilized to their best. So one example, and just looking at things culturally, is, many of us talk in healthcare about this growing fear around childbirth in North America and everywhere. But we're really good at it in North America, of making childbirth sound like the most terrifying thing that could happen. And I do think there's amazing strength in many of the Caribbean and African communities I've worked with, that childbirth is still seen as something that is normal and doable. And I really wonder sometimes, working with communities who really hold that belief, how do we bring this back to the mainstream instead of having what usually happens is that people, the longer they're here, get more westernized and adopt the kind of fears that we have. I also think there are amazing things in terms of postpartum culture. So we really have lost any sense of postpartum culture in the West, and this, ideas around care for postpartum pregnant people, so not necessarily around women. And that's where sometimes I think there are amazing strengths of North America in terms of our ideas of equality and inclusivity. Not that we always do it that well, but we have really good ideas. But a lot of traditions, especially around the care and also actually seeing birthing a person, however you do that, as an important act for humanity. Like, we've really lost that here, and so I wonder how we can bring back those strengths around postpartum culture and even old traditions. And I think of this a lot with especially newer immigrants who are lonely. I mean, many people's experience moving to North America is how utterly lonely life is here compared to where it is back home. And I think women experience, and all bodies that can be pregnant and postpartum and even share in that experience a huge amount of loneliness in the immediate postpartum period. And I really wonder that these also, at the same time, we have older immigrants who are aging and not involved in our society in the same way. And I think there's a huge support system there and knowledge base that we're not connecting. And I think those are some places that could actually not just really benefit Black cultures in particular, but actually be models for how we keep integrating the importance of culture into different stages of our life, but also the connections between our elders and our younger generations that we've really lost here, that I think are really important in immigrant communities.
Thank you.
I think at the policy level, the strength that can really be leveraged is truly the voice of the patients. And I think, when you make a statement like that, it does sound like a judgment that why isn't that voice there? And I think that at the policy level, we do need to own some of the responsibility for that, because the extent to which we've been able to engage the patient voice has not always been representative. It has not always been open and welcoming to people from all different diverse backgrounds. And I think that one of the opportunities that really exist for us is to think about how we do that in a much more inclusive way. And whereas in the past we've had, policy development committees and working groups, we bring together professionals during business hours to come in and develop policy associated with maternal and neonatal services. We invite one person to represent all patients. And who is that person? It's somebody who is available during business hours, who can come and attend a meeting, who can make it to a location in downtown Toronto, and who has the luxury of time to be able to participate. So we end up getting a very slanted perspective of what the patient voice is when we consistently engage in a manner that represents only a small portion of the diversity of patients who actually receive care. So I think the strength that we are really looking to leverage, at least from a policy development perspective, is how do we get that voice at the table, because it's there, and it's just really falling, I think, more on us as policy developers to make it easier and more accessible to do that. So at least on our end at PCMCH, we're looking at new mechanisms of engaging broader, more representative patient voices at the table. We're looking at engaging with online communities in an asynchronous manner, so it doesn't necessarily have to be when we're arranging to meet and have a discussion about a particular policy topic. And I think the more we can make efforts to bring those voices to the table, the more the strength of that voice becomes harnessed and becomes a much more powerful enabler for policy change at the highest level.
Thank you. I think a lot of these conversations for me reflect some of the things that I'm aware of, but at the same time, I think something that is missing is some of the kind of informal spaces, collectives, and digital spaces that we've been able to create to kind of build that solidarity and to have a space to literally ask, is this normal? And not have to ask that question to your healthcare provider every time you have an appointment, and having other Black parents who could share that space with you. I know that with my sisters and my cousins and other people in my family who have had children. I mean, I was the first amongst in my generation, so that was the text messages that I would get. This and this is happening. Is that normal? And literally just having that kind of collaborative and having a space where your ways of knowing and being were also respected, and you could come into the conversation knowing that was the baseline, was really helpful. And also having a culture of care, really. Some of what you touched on is that interdependence in community care throughout pregnancy and beyond that, and kind of building a model for the ways that our communities have always done these things, and kind of institutionalizing that in whatever ways are possible, and really just having a space for empathy is really, there's a big power in that. There's something we call the Black people head nod. If you're not Black, I'm about to let you in on a little secret. Okay, you are two Black people in a room, the only two Black people in a room. You see some wild shit go down, okay? You look at the other Black person in the room and you're just like, and they're like, yeah, I saw that too. There is something really remarkable in that, from like an emotional health, for your mental health, for empathy, emotional uptake, all of that. There's something remarkable in that, and having spaces to do that are both immediately available to you, but are also, digital and virtual spaces is really critical, because there's a lot of...
do the nod on the virtuals.
you probably a meme, a GIF, a yo, just tag you. My sisters and I, they just tag me in the comment of something, and they don't even have to say anything, and I'm just like, yep, that was whack. I'm not about it. That was it. So I think having that space is really, really critical, because it also helps you feel like you're sane. When you're in a position when you're constantly being told, which you're trying to advocate for yourself, actually your perception of your reality is not what you think it is. Maybe you're not right about this. Maybe you're confused. Maybe you're emotional. Maybe you're just drugged up. Whatever that may be. That's institutional gaslighting, really, that you get from like healthcare professionals. It's really helpful to have a space to offset that may or may not be a formal space. And as an educator in the work that I do, I really believe in spaces for deinstitutionalized learning, where doctors, healthcare providers, midwives, doulas, everybody who's in maternal health or adjacent can access conversations in spaces like this one. And I think it's really critical to integrate that into what we think of as, an education to be a medical professional. Having a space like that, and there are spaces like this across the city, but it would be really great if there was like a centralized place you could access all this information. That would be dope. I don't know if anybody has the power to make that happen, but that's what I want for her birthday.
I don't know if that's gift wrappable, so we'll work on that for your birthday. When's your birthday?
On 2 weeks, so
That's-
you got a little bit of time.
That's a little quick. Yeah, so you kind of touched on what I was going to say. One of the strengths, I know that we have a love-hate relationship with social media, but for all the bad and the trolling and the ugly, there's some amazing things that can come about it, and BMC is definitely an example of that. It is a safe space. We have an admin team who's amazing, who helped me filter to make sure that it's Black women getting into the space. There's a lot of non-Black women who try to get into the space. There's a lot of men who try to get into the space who are like, I'm looking for a girlfriend, I'm like, that's not how this is supposed to be going. So that's first and foremost the key and utmost thing, and it's a space that becomes really raw, and we share a lot with each other. We asked those exact same questions. Is this normal? Why I started BMC was I was looking for sunscreen for my son that didn't turn him that kind of like pasty gray, weird color, and I'm like, is there a sunscreen for Black skin? Do I really have to pay attention to this? And so those kind of questions that what I've heard time and again is when women are in, general mom groups on Facebook, they can't ask racial questions without being, oh, you're just playing the race card, you're being paranoid, you're, same gaslighting that happens and microaggressions that happen. So this is a space where you don't have to worry about asking about, can I put coconut oil in her hair at 6 months? Like, that's a normal question that probably gets brought up pretty often, especially our new moms. I love seeing the pictures of the babies. I have so many BMC nieces and nephews that were born like just in the past 2 weeks. And it's super powerful, right? And it's bringing back the whole notion that it used to take a village to raise a child. And so when I call them my BMC nieces and nephews, it's true, except for I don't have to take care of them in any way, shape, or form, so that's great. And I think it's just a matter of like, if you know that you have support, if there's one space that you have support, then it can drastically change how you feel about a certain situation, whether it's breastfeeding or, trying to get your sexy back after you've given birth, or managing a new relationship, or do you have a favorite child? Like all those types of situations and questions that mothers generally don't get to have, right? Like talking about the regrets of motherhood and being exhausted and tired and just wanting to kind of walk out. There's usually not a space for mothers to have those kind of conversations. Specifically now you talk about Black women wanting to talk about certain things. So I'm really, really proud of the things that we've been able to build. And I think just outside of BMC, now I'm seeing more than ever, there's a movement towards representation mattering. So there's a Facebook group online, and people are just like, I'm looking for a Black chiropractor, I'm looking for a Black mechanic. Like they're really making an effort to seek out people who now just get it. You're not going to have to explain why I believe a certain thing that I believe or act a certain way. They're just going to get it. And I think eliminating that need to explain the history and the root and the cause of who we are and how we move and the Black people head nod takes a lot off of the stress of accessing any type of care, whether it's prenatal, mental health, or otherwise.
I'm actually going to take a moment to say thank you, because I actually use your platform and have since before having my youngest son. And that for me was the best way to combat that mom guilt that is overarching, and like you're guilty about literally everything. So it definitely was a space to like deal with that. And that was super good for my health. So I'm grateful to be sitting up here with you. Thank you.
That's awesome.
Yeah. So I'm gonna skip some questions. I feel like Elsie's gonna come up here and talk to me about time. So I don't know. Was I being warned already and I missed it? Because I was just like in awe of everyone. Okay. So
Can I just add one very quick comment on this? Certainly, I think like as a human being, I think it is a characteristic of all human beings that we always look for identity. We'll always look for somebody who looks like us. All right. So that's why I think that having certainly culturally competent physicians, nurses, midwives, social workers, is very important. But ideally, as we live in this great country, I think ideally what we would want to see is a delivery system where it shouldn't matter the color of your skin, it shouldn't matter how you look, where you are from. You should get the same care, whether you are black, South Asian, Caucasian. It shouldn't really matter. I think that's the system, or I think we're going through our strategic planning, but in our vision, I think that's really what we should be aiming for.
Okay, so I'm gonna kind of merge two of our questions into one as best as I possibly can. So we're looking at the ways in which racism in maternal health impacts patient health. Can you tell me about some culturally competent maternal health care services in Ontario or beyond?
So I'm going to ruin your plans.
Let's do it.
Because I kind of answered that question before, but I know that because I have the script, I know some of the questions that you're skipping, and there's something that I really want to talk about.
Please,
And
let's
I was
hear
looking
it.
forward to being first. So it was.
She's calling an
So
audible.
I'm completely ruining the plan. Part of.
There's time for the Q&A too, though. Yeah.
But when it comes to, so part of the question was going to address poor outcomes that Black and racialized women face with regards to maternal and also for the newborn. Okay, and basically the bottom line is racism is bad for our health. Okay. Race is a social construct. It is not a biological construct. Most of the time when we see racial differences, especially when it affects many groups, especially many non-white groups, it's because of social issues, and usually those social issues are linked back to racism, okay? So where we exist in a structure that is where systemic racism is so pervasive, as identified by the United Nations, so it's not my opinion, they told us here in Canada, it exists, it's deeply embedded, actually, to quote them, in our systems and structures here in Canada, where we have a structure that is really based on, that kind of Eurocentric, settler perspective that what is, European or white in appearance, in worldview, in religion, in professionalism, in every way that we think about carrying ourselves or perspectives or beliefs, that is what is superior and that all other groups are inferior. That leads to the microaggressions that we were talking about, or the unconscious bias, or even the underrepresentation of Blacks in medicine and other areas. But it is that perspective that permeates through our society. There have been studies, yes, they're from the States, but there's no reason to think that they don't apply here, where they've looked at birth weights. There are studies showing that Black, especially African American women have children of lower birth weights. And they said it was genetic for a long time. But then there were studies in the late 90s, so it actually isn't news, it's just that we don't like to focus on those types of papers, but really substantial research showing that when you looked at West African immigrants, right, and who came to the United States to have their babies were the same weights as the white babies, essentially. Like, the weight distribution was the same. It's African American women that stood out. And so what was the difference? They basically would have had similar ancestry or genetics. It was the social conditions that those women were living in. And what's even sadder is that they did an update to that in 2002 and looked at second generation, so people like me whose mothers were immigrants, and looked at the birth weights, and the birth weights of their children were similar to the African American population, because those women were living and growing up in a situation of systemic racism and poverty and social deprivation. So where we see worse outcomes, it's not impossible that sometimes there might be some genetic predisposition, okay, but really what we need to be addressing and advocating about is where we see those differences. If race is a social construct, then those are social issues, those are racial issues, that is based on our history of systemic discrimination, and I'll speak specifically to anti-Black racism, and so we need to really advocate on that issue. Sorry. Really wanted to say that.
Thank you. Let's run with this question, yeah?
I'm kind of jumping the mic because I wanted to make sure we get the question too. But one of the ways we talk a lot about decolonizing the classroom and, what does that mean? One of the things I say every single time we come across a study that says this is more prevalent in Black and Hispanic populations, I say to my students, every time you see that, one, think about the amount of research generated from the United States. So every time you see that, I want you to think intergenerational poverty and intergenerational racism. And we know now with things like epigenetics, for example, that intergenerational trauma does affect our biology. But also, on top of what you were saying about, like one of the other issues that, and I try to teach this in the classroom, is our ideas of physiological normal are almost exclusively on middle-class white men, and if we're really lucky, middle-class white women. But there is nothing on anything else. So there are, we know, differences in race in terms of, potentially, in terms of how people birth, the birthing curve, for example. And things like that, you know, the birth curves we use of what normal labor progress is a 50-year-old document done on 50 middle-class white women in California, or 150 white women, I can't remember, but it's been critiqued a million times, and yet that is what is still used in hospital to determine, are you laboring too long? Is this an abnormal labor? Are you going to C-section? And I think in this era of hyper-technology, what's interesting is we're finding that, for example, in the United States, you have both. You have people who don't have access to care and who are not having life-saving cesarean sections when they're necessary. And we're seeing the opposite, people who don't have voice or their physiology is seen as abnormal and they're having too much surgery. And we have to look at how those everyday effects of racism are impacting everyday decisions about people's health care.
Thank
Sorry,
you.
that was my jumping.
No, I'm with it. Let's go.
I think, you know, with regard to both Black and Indigenous populations, one of the challenges that we've certainly identified across the province is both the access to specialized services for perinatal care, but also the ability to access culturally appropriate services in that regard. And I did have an opportunity over the past year to visit some of the more remote Indigenous communities in northeastern Ontario. And I think the most eye-opening aspect of that visit for me was, you know, we had walked in saying, well, you know, we can provide you with these resources and these supports, and the communities said back to us, you know, that's great. You can stock up our nursing station. You can provide all of these materials and resources. But the fact is, nobody actually comes here and says, I'm pregnant. There's such a fear of acknowledging that somebody is pregnant because of the risk of having the baby apprehended, because of the risk of you know, the services all coming into play that have in the past, that have made these young women so afraid to come and even acknowledge that they're pregnant, that they're not able to access prenatal care. They don't even get access to things like the basic vitamins that for most of us would be, you know, something we wouldn't even give a second thought to being able to access. So as we think about that specialized services and the supports, we can certainly make efforts to build them, but if we're not doing it in a way that's culturally appropriate and that is recognizing those systematic barriers that exist to patients being able to access what's there, we're never going to actually see any changes in terms of those improved outcomes. So I think as we build out our models and we think further about this, and I believe earlier today there was some discussion about efforts being made at the Association of Ontario Midwives to bring in a more robust approach to building out Indigenous midwifery in Ontario and strengthening the roles of those types of service providers in the province. There is really that broader approach to being able to address those outcomes and recognizing that that the way in which we provide care, even if we have access to the best equipment and the best materials and training, needs to be delivered in a way that is cognizant of what that patient population actually needs and the supports that they require. So I think the question of outcomes is really multifold. We can talk about it from the perspective of specialized services, but we can also look at it from that lens of what is culturally appropriate for any one group and recognizing those specific needs.
Me? Oh, I have nothing. I don't even know what the question is because I know that we kind of took like no, but there was like an audible called, so I just.
It's a remix right now.
I know,
so,
right?
Yeah.
Like it's part 2 of the song. Yeah. So which question am I answering?
So, Boo, it's up to you. You can either talk to me about how racism in maternal health impacts patients' health, or you can talk to me about why Black and Indigenous women experience higher rates of pregnancy and childbirth complications, or you can talk to me about culturally relevant solutions. I'm gonna let you pick.
Okay, I'm gonna go with door number 3. Mostly because I am not a doctor or a midwife or working in policy. I'm just a mom who works with a lot of different moms in a lot of different capacities and areas. And I mean, I've spoken on it before, but I think there's really something to be said for being able to have spaces where you can have access to culturally relevant tools and resources. So for example, and this is not a plug, but it's an actual example. So Black Moms Connection we did last year, we hosted our first conference, and we talked about navigating the education system. So we had a trustee and we had a Black teacher. We talked about health and wellness. We talked about financial literacy. We talked about special needs. We talked about law. And these, all of our panelists, and this was done very purposeful by me, all of our panelists were Black women or racialized women. And so in March, we're doing a day called BMC Finlit. So it's a day for and by Black women, and literally the whole day is about financial literacy. So everything from unpacking how we got here to feeling about money in the Black community to, you know, budgeting hacks, why GoFundMe is not life insurance. That's personal to me. We'll talk about that later. Wills and estate planning, and I think for me, what is a really, really important thing is money is generally the great equalizer in the world. Mm-hmm. So I want to make sure that we are getting the education and the tools to empower ourselves now. Like, okay, here's how you fix your credit. Here's how you can apply for a mortgage, and talk to women who look like you, who just get it. So it's going to be a day where you're going to have conversations, because our community doesn't talk about money, right? We're not supposed to ask our parents how much we made and all these kind of things. So now having a day where you have to face those kind of things and you can feel safe to ask those kind of questions and talk about, okay, I have bad credit, or I don't have a will, or I don't have life insurance for me and my son, or whatever it is. It's super important to me, again, that all my panelists and speakers are Black women who can speak to these Black women about educating themselves financially, because it will directly impact them as women, them as mothers, their families, the community. Like, it's a domino effect, times 10 as you go up each level. So I think that's something that I feel really strongly about, and I know that sometimes there's some backlash, but there's a reason for it, right? Culturally relevant healthcare, culturally relevant conversations can only do good for that community internally, the in-group, but also the out-group, right? If we feel empowered and healthy, mentally, financially, emotionally, physically, then that can only have positive benefits us as employees or employers or consumers or customers. Like, this is not just about making the Black community better, it's about making all of society better, but I'm just sticking to the people that I know.
Thank you.
No problem.
Yep.
I don't think I have much more to add to what has been discussed, other than to say certainly research is very important collection of data, racialized data, is very important, certainly in policy development, in planning for the future and planning for for correcting whatever we may want to correct. We have to have data, and that data in Canada does not exist. So we are strongly advocating for collection of data. The second maybe part to the question, especially in terms of outcomes, I think education, as we said, is very important. It's very important that mothers that are here, I see one gentleman here, so I feel okay. Oh, there's another one over here. Yes. Onya alluded to this, that when you look at the immigrants who come here, and then we look at the second generation immigrants, the second generation immigrants would be, sometimes get more, will be much more affected by the social issues that they will find here. So it is very important that we educate our kids, that our kids, certainly through maybe a proper use of social media, they get connected and they learn about what you are doing, what other people in the community are doing. Certainly in the Black community, like in any other community, there are certainly social workers, there are teachers, there are lawyers, business people, doctors. So those, lawyers, those people need to be visible, come out and, give back to the community. So I think that piece is also very important in influencing, future outcomes. And the last, maybe very quickly, in terms of maternal health outcome, also. This was complications of exactly for complications of childbirth compared to white women. Certainly, this statement can certainly be confusing because there is no data. This is again an issue of data, because, for instance, I can tell you if I looked at one just specific cause of prenatal birth, which can lead to complications. The number one cause of prenatal birth is actually what we call iatrogenic, because there is a medical condition that is warranting that. For instance, if there is gestational hypertension, gestational diabetes, or there are fibroids, all those things. So if I narrow down and quickly looked from my experience on fibroids, for instance, they say that the prevalence of fibroids is very high in the Black populations. But actually, when you looked at that, it is not true, right? Fibroids are prevalent certainly in people with a darker complexion. When you looked at, for instance, South Asians, they have a lot of fibroids. They have the same issues as Black populations. So this, as you are saying, it is very important to put in a context that some of these statements can be made. When they say something is really prevalent in a certain population and not the other, you have to question really on what is being talked about.
We don't have a ton of time, but I want to take a few questions from the audience. So if you do have a question, the microphone is right over there so we can hear you clearly. If you want to, and over there, yes. And if you want to make your way over and ask a question, please get to the point super quickly, and not 2 paragraphs, and we have to somehow distill the question from in there, okay?
That is the best moderating note ever.
Thanks. I have no manners, no problems being rude at all. We literally answered all of your questions. It was that brilliant.
Yes.
That's great.
I like this. Okay. So Elsie, do you want to move into our break? Is this what's going to happen now?
Yes. So.
Come on up, Boo.
You were expecting questions, weren't you?
Yeah. No. I think as to round it up, just very quickly, since you guys don't have any questions. Maybe just briefly, if you all could speak to one thing that we could do moving forward to improve care for those who are culturally competent. Outside of what we've discussed, because we've discussed services that are available, what are some of the challenges and complications, but what can we do in your various fields or various areas of expertise? What can be done to improve maternal health care for these populations?
Okay. I think we'll start with you. This was your turn to answer the question first.
So this is a simple solution that people are going to think sounds impossible, but I think if you live in Canada, regardless of what your immigration status is, you're having a Canadian baby, you should have access to the healthcare that you need. That's it.
Thank you. Right. If you want to clap for that, I will hear it. My one thing is that
free.
Ask the people who are in, your patients, your clients, what do you need? There's something remarkable about that question that puts the agency back in the hands of someone who is constantly being told, no, you don't have actually insight on your own lived experience and your own current experience. What do you need, and how can we support you? I think there's a remarkable power in that question.
I'm actually going to underscore, Rania, your favorite piece, which is the data. I think if we can get to the point where we actually have the data that can inform how we design and develop policy, the data that supports changes in how we implement practice, it makes all of these arguments so much easier. And to your point, you don't have to actually sell the story. The data speaks to it. I think we have some representatives from BORN, the Better Outcomes Registry and Network, here today, and this is one of the issues that we've certainly discussed at the BORN level around how to make sure that the data that we do collect on maternal and neonatal outcomes and services does reflect the true diversity of the patients. So I think if we can start from there and build from a point of true and objective information, it really gives us an opportunity to strengthen what we're able to do.
Thank you.
What order?
Sure, go ahead. Over to the,
Oh, I'm going. Oh,
Yes.
oh, goodness. So quickly, we have more conversations and events like this, so we can have these conversations and bring together diverse groups as well. It's not just racialized women, obviously, in the audience, so I think that's super important as well. And build more spaces. So, government partners should help us find spaces where women and people can access the care that they need. There's space there, there's grants there, so there's no reason why we can't build a West End community space, York Region, whatever it is. And those are my suggestions.
Thank you.
From my perspective, it is very important to be at the table of discussions where issues are being discussed, whether it is in the board room at the hospital, whether it is at the universities, whether it is at maybe the social services. We need representations everywhere. And also very important, you mentioned this about finances and financial literacy. It is very also important to participate at the economic table. Okay, if we're gonna change things, somebody mentioned this before, money matters. So it's very also important to participate at the economic level, because actually one of the biggest things I think that influences everything is economic power. So we talked about so many other things, but no one actually mentioned ever economic power. So we do need also to participate at the level of economic power.
Thank you. That means come to Finland is what he's really saying.
So I think I'm just going to kind of reinforce some of the messages previously. Of course, economic power is really important, but there are a number of kind of, international studies showing, so not just in the United States, that where, you've got systemic racism, even when you you control for socioeconomic status. Those who are racialized, but particularly in the States, African Americans still have worse health outcomes because racism is a chronic stressor that just wears and tears on the system. It's a term called weathering, actually, if you want to Google that. It's an actual term of what is happening to us, why we have diabetes at an earlier age than the white population and hypertension. It's weathering, and we also see it in, white women can have it, but in situations where, let's say you're the mother of a child with autism, it's an everyday upward battle, but we see that across, people of African descent in Western countries, but in particular women, so Black women, because we're both women and racialized. So along with, economic power, I think we also need to speak our truths, and those who are not experiencing it, then, you're in the room here today, please be allies. We need, especially in Canada, to talk about racism. It's this bad word, it's the R word. It's, when we're at the board tables or we are given a survey or whatever, sometimes we try to find euphemisms and all types of things to dance around it. I think now is the time we need to speak that truth to power, that there are injustices happening, and so racism is really important. And although, we have our anti-racism directorate, that there's as of June, the collection of race-based data is mandated for a number of, pretty much all of the ministries except the Ministry of Health. And so in healthcare, we need, anyways, they were exempted. So we need to be at those tables whenever possible to continue to advocate for that. So that's what I want to say.
Thank you so much. Thank you, everybody, for being here. Feel free to, I know that there will be, follow-ups and
Placid has to deliver a baby, so bye.
Babies are forever not on everyone's question. There's a question. Go ahead.
I don't know if this is working. So I'm not in healthcare, I'm a mom, and I want to know what is the work that is being done in terms of creating the safe spaces. My issue was interacting with healthcare providers, and unfortunately it was midwives, it was also OBGYNs. So how are we creating doctors and midwives who I don't have to educate on how to talk to me? Is that making sense?
Okay, yes. So it's a slow and steady process. I was speaking to somebody at the Anti-Racism Directorate, and she quoted an Indigenous elder who said, if it takes 2 days to enter the deep of the forest, it takes 2 days to come out. And so that's a bit of the bad news here. The racism that we know is from centuries of oppression, and so it's not going to be reversed overnight. However, there's progress. So certainly, the University of Toronto was identified, first of all, they identified that Black students were underrepresented, but then, in medicine. So it's not across the board that they're doing that, but in medicine. And so they have, a stream for Black students to apply to medical school now, but also hired me as the Black Health Theme Lead to teach all the medical students, not just the Black medical students, but all the medical students about issues that affect the Black population. And where I'm starting on, of course, because race is a social construct, is on racism. That's the basis from which everything else follows. And so I know that's happening in other circles, and that's happening in social work and other areas. So I think the beautiful thing is, it's going to take, another cycle of people, if you like the generation that's in school now, to start to have, have that lens, but it's starting to be there. And certainly there's allies, some of these young medical students creating groups like the Social Justice and Medicine group, kind of forcing the senior physicians who are more conservative to address these issues, because they're seeing Black Lives Matter out there, they're seeing Idle No More, they're seeing #MeToo, and they're like, what's happening in medicine? So it's really great that actually it's being pushed by the students, but change is coming.
Thank you. I get the opportunity to do that work in a lot of spaces, but particularly I get the opportunity to do that work with medical students, midwives, and doulas, to have conversations about, is racism, Islamophobia, homophobia, transphobia, classism, and the intersections of a lot of different oppressions. So I do it helps me to combat that it's all going to hell feeling. Really, when I get invited into a space and they're like, we actually want to talk about these things, we don't have the language, we don't want to harm people, we know we're harming people, we don't necessarily know how. So finding more opportunities doesn't have to be me. There's a lot of brilliant consultants out there that are doing this work, and bringing them into your spaces and not waiting for that to be a reactionary thing when something goes horribly wrong and people are harmed. You can invite that kind of critique, you can invite that kind of engagement, you can invite that kind of learning into your space, and then you can reduce the harm and you can create better outcomes for your patients and your clients.
I think we really need to, especially at the educational level, I think interdisciplinary education is really important. And it shouldn't, I think part of what we're grappling with at the educational level is we're all kind of reinventing the wheel. And I think it would be really good to look at what best practices are. So for example, Sick Kids Hospital initiated equity training for every single person, from the cleaning staff to the medical director. They had to go through the same equity training, and they continued to do ongoing equity training. And I think doing something like that, where you're not just talking about the importance of equity, but you're putting the money behind it because you recognize it's actually going to change the lived experience of the people that you're serving. I also think one of the big things that we don't talk about when we talk about economics and visibility, because I think representation really matters, is we have a huge force of racialized physicians in this country that we don't allow to practice. Yes. because of systemic racism. And that, to me, there's so much knowledge about cultural competency that's inherent when you have a lived experience of being from somewhere else, that I think we need to also find pathways for those people with the education to be able to practice here and bring their knowledge here.
Anyone else want to add anything? Ooh, a new question, Sonora.
Hi, Rania.
Hi, Boo.
I had two questions, and I'll try and make it quick. One is around, because I know it was brought up earlier that community health centers are a great place for those with, I guess, precarious status. But it's been my experience when I have called some of those community health centers mentioned that they'll tell me, right away, because I'm calling on behalf of someone, that, no, we can't help them. But women's health in women's hands, I know can, because I'm a client there, so I know that they can. But Taibu, they cannot if they have that status. So how can we make sure that those at the front end of the communication are aware of what they can and cannot do, because there are many people advocating or calling on behalf of others who are not getting that support that other people will say exist. And then my second question is around, so I work with a lot of families with children with developmental disabilities, and they'll go to ethno-specific organizations or health centers that they think will help them, but then they find they're not equipped or uncomfortable or don't have the training to feel that they can take on their care. So maybe some of the other folks here have some ideas on what's being done there, or what they think can be done to create spaces where others who don't fall under a single access of identity can also access that service.
Yeah, so I think I can probably only speak to the first question about access at Taibu. And so I don't know the context of the patient that you were trying to refer, but community health centers definitely have a broader ability to help people, but they're still limited by the policies of the Ministry of Health and Long-Term Care. So if it's somebody who's like a visitor and undocumented, that's not possible. It's really kind of, like you're staying here and undocumented. So even within that category, unfortunately, there are subcategories. Also, geography matters and race matters for Taibu. So because the mandate is to serve the Black community in the Greater Toronto Area, if you live in the Greater Toronto Area, you can become a member. Or if you live in like that geographical area of Melbourne, if you're not of African descent or identify as Black, you can also. But if you happen to be outside of Melbourne and you're not Black, then unfortunately it doesn't fit the policy or the mandate. So there are those. So, but really it's hard to know that in advance, because these are like little subcategories of policies. So unfortunately, the only thing you're going to be able to do is kind of like call the different agencies and find out what their specific sub-policies are. But again, it's not usually the agency's decision. It's come through the Ministry of Health and Long-Term Care and what they're willing to fund and not fund, unfortunately.
I'm going to say what I said before, which is that CHCs are amazing, but they are seen as the panacea in our healthcare system. As soon as you mention that someone's undocumented or has complex needs, which are many racialized people, people will say, okay, go to a community health center, and they're closed, they don't have the people power, they don't always have the knowledge base. And I say that because often people who are pregnant that community health centers can't take will end up on my doorstep. And so I think we need to have a broader understanding among community health centers of what those subcategories are, because not only are there geographical and policy differences, but who's undocumented at one CHC will not be considered an undocumented person at another CHC. And that understanding of what's happening in our immigration system is really important. But I also think we need to make more noise and have people understand. We have this narrative of people who don't belong here coming and trying to use our system. And I always say people who are undocumented have no access to anything in our system. And this idea that, well, they're not taxpayers, these are people we're not allowing to pay tax. And I don't know anybody who can buy a chocolate bar in Toronto without paying tax, regardless of what your status is. So that argument that these are not taxpayers or people who are contributing to our society, it's been refuted in research. And yet I worry that our mainstream collective way of thinking is we have nothing to do with colonialism and 500 years of why half the world is poor and very few of us have wealth. We don't think about Canada's responsibility in that. But so we have all of these ideas about who is allowed to be here and who's not allowed to be here. And as a settler nation, I think we really need to relook at that.
Thank you.
One more comment in terms of the supports that are being built out. Public Health Ontario is starting to take a bit more of a role in this space, and I think it's a starting point. There's a lot more work to be done, but right now there is a study underway to look at populations that are overrepresented, for example, with gestational diabetes. There's a nursing secretariat initiative around providing outreach nurses to go into the homes of populations where there are recognized social determinant of health challenges. And right now the focus of that initiative is very much on breastfeeding support, but I think it does have the opportunity to kind of grow from there and to strengthen that. So as we think about access and the opportunity for nurses to provide services in the home, for other health services providers to go into communities and to actually be where the patient is rather than having the patient try and come and access services that may be a barrier. There is some work underway to start to alleviate those barriers.
So sorry, before you go, sorry to interrupt. No. We are over time, but if you have a very, very brief question/comment, and if you have any questions or comments, feel free to ask the panel after. Yeah, thanks. Sorry about that.
Okay, no, that's okay. Okay, how about like 2 minutes?
Less than 2 minutes.
Okay.
Yeah.
I'll just save mine.
Oh, okay. All right. Yeah, sorry about that, everyone.
Gotta do what you gotta do.
Sorry. I had to cut it off. I had to Kanye that. So thank you, Rania, for your amazing moderating skills. Thank you to the panel for taking time out of your busy schedules to come here and speak about your work and to, answer some of the questions that I'm sure a lot of us have. Again, apologies for, like I said, Kanyeing it, but hopefully some of the members of this panel will be here after so that you can chat with them. So we're going to have about a 10-15 minute break right now. Again, like Elsie said at the beginning of the day, there are posters on the side, so feel free to take a look at the posters and the amazing work that a lot of people within the field are doing. And then once the 15 minutes are up, I'm going to come back and either yell or sing at you to come back. All right? Thank you.
Thank you.
All right, everyone. let's come back together. I think I'm gonna have to sing. All right, everyone, let's get back together. All right, everyone, let's come back together. Let's start this again. Let's come back together. All right, panelists, get off the stage. All right, is this on? Sorry. I know. All right, everyone, please get back into your seats. Please. We're going to start back again. I'm just going to keep singing until everyone sits down. The posters are amazing, but you can look at them after. Please, everyone, take your seats. You can network later. Everybody, let's come back together. Everyone, let's all take our seats, please. Let's try to get out of here on time. I'm just gonna keep singing. Let it go, and please sit down and watch the show. We're at a maternal health conference. Everyone, please have a seat so we can start back up again. Thank you. Let's start again. Everybody, have a seat. Let's start again. Everybody, have a seat. Let's start again. Everybody, let's start again. Now you're paying attention to me, 'cause I'm singing. Everybody, let's start again. Take your seats. I have no water up here, so I can't sing for long. All right, looks like we're almost there. Thank you. All right, so we're almost there. Looks like almost everybody's grabbing their seats. I ran out of saliva because I've been singing for longer than I anticipated. All right. So thank you, everyone. I know this has been an amazing day, chock full of amazing panelists, speakers. I know there's been people, networking and whatnot, but hopefully we can come back together and listen to two amazing people that will be coming up shortly. So first we have Dr. Simone Vigod. I hope I said that correctly. I was close, I'm sorry. I try. Okay, thank you. So this next session will be on postpartum depression in mothers and fathers. So Dr. Simone is Associate Professor in the Department of Psychiatry at the University of Toronto and lead of the Reproductive Life Stages program at Women's College Hospital. So everyone, if you can just welcome her. Thank you. Oh, sorry? Oh, I'm gonna do them after. Oh, oops, okay. Okay, you want to give his talk? Okay. All right, so it looks like Dr. Howlett's actually going first. No, I'm going first. Oh, okay. I'm so confused now. But you know what? I'll do Dr. Howlett as well. Can we get the right slides up? Well, whoever wants to go first. Yeah. Okay, sorry, folks, we're having a little bit of technical difficulties, but Dr. Howlett will be speaking after. So we're all in the right place, but just we're flipping it a bit. All right. Again, thank you for sitting down after my long singing debut and performance. Yes, thank you. And thank you to everyone who clapped along with me. All right, so we have the right slides up, and Dr. Simone, take it away.
Thank you very much, everyone, and thank you for staying to getting close to the end of the day to hear about a topic that is close to my heart and close to Dr. Howlett's, who's going to speak also in this session around the health of parents during pregnancy and in the postpartum period. And just as a plug, it is Bell Let's Talk Day for mental health. So if you're going to tweet out any of this or any of this information, be sure to add the hashtag Bell Let's Talk, because every time you do that, Bell will donate 5 cents to mental health care and mental health research. So my job to begin is to talk about maternal mental health in pregnancy and postpartum, which will be followed by paternal mental health afterward, because really I think we want to talk about the health of the family. And I think I would speak for both of us to say that when we're talking about mothers, fathers, women, men, we would put asterisks there and talk about women, meaning anyone who identifies as a cisgender or transgender woman as well. Here are my disclosures, because I'm going to talk about some of the research from our own clinical program here. I just wanted to acknowledge the funders of that research. So perinatal mental illness, perinatal being generally the time referred to around pregnancy and postpartum. It is one of the most common complications of childbirth, up there with postpartum bleeding, up there with nausea and vomiting. 1 in 5 Canadian women. There are about 400,000 births in Canada every year, so we're talking about 80,000 mother-child family groups affected in every given year. More common than some other mental health problems that we routinely screen for and treat in pregnancy and postpartum. The most common mental health issues that women experience around pregnancy and postpartum are depression and anxiety, but we often hear about postpartum depression, and I think postpartum depression, it's good, it's a catchword, but I think it's important to say that it probably is a euphemism for postpartum any mental health issue that someone is having in pregnancy and postpartum. And so this is really just a reminder to say that there are other serious complications that can occur, including mania and psychosis, as well as substance use disorders. And the other point I like to make when I'm giving this talk is that mental health problems can occur new onset in pregnancy and the postpartum period, but the reproductive aged women are at high risk for mental health problems in general, regardless of whether they're pregnant. And most women with mental health problems or psychiatric disorders become pregnant. So I think it's important not just to think about this when someone is arriving in our office pregnant or with a new baby, but actually also to be thinking about this preconception in pregnancy and then all the way to the postpartum, which absolutely, for a multitude of reasons, is considered one of the highest risk times for either a new onset or a recurrent maternal mental health issue. So what are the risk factors? It is true that if someone has the risk factors for depression in pregnancy or postpartum, or mental illness in pregnancy and postpartum. So it is true that if you have a personal history of a mental health problem, if you have a family history, so there is actually some genetic data to show that sisters may be more likely to have a mental health problem around the time of pregnancy if your sister did, or if your mother did, or if your grandmother did. Treatment discontinuation, there's a lot of medication discontinuation that occurs around the time of pregnancy, and sometimes that's okay, and sometimes it's the right thing to do, but it may still be a risk factor for someone to have a relapse. Probably the biggest, and those I would call sort of biological risk factors for developing a mental health problem around pregnancy and postpartum, but there are also very strong psychosocial risk factors. So having inadequate support around the time of pregnancy and postpartum, and that can be inadequate practical social supports. It can also be inadequate emotional social supports, as well as having major life stressors. And major life stressors really is a catch-all term, but there are risk factors that include very serious things like domestic violence, but can also include marital discord, financial problems, or sometimes a complication of the pregnancy or having a sick baby. What I put down there at the bottom, though, is what I think is one of the most important things that I talk to women about in my clinic, is that this can affect anybody of any age, of any marital status, of any culture, of any color. You can have no risk factors at all, and it can just happen to you. And I think that it's so important to say that, because I cannot tell you how many women come into my clinic and feel like somehow it's their fault, or they should have known it should happen, or there was somehow something better they could have done, or stronger they could have been, and then this wouldn't have happened. And so I really do like to highlight that sometimes there are no risk factors at all. So what are the consequences? Why does it matter? Well, first of all, for the woman, for the mother herself, experiencing symptoms of mental illness such as depression, anxiety, sadness, low motivation, problems sleeping, problems eating, problems concentrating, being so anxious you can't concentrate on what you're supposed to do next, right? These are problems that are going to have negative effects on daily function and sense of well-being. And they're going to affect not only the mother, but also the people around her. There is also some evidence that when women are very anxious or very depressed, this can also impact on some of their behaviors. So they may not be able to get to as many appointments. Or sometimes they may be self-medicating, either smoking or having difficulty quitting smoking, using substances that could impact the growth and development of the fetus. And so untreated anxiety, depression, or other mental illnesses during pregnancy have been associated with poor fetal growth, preterm labor, infant irritability, and then both untreated depression, anxiety in pregnancy and postpartum untreated depression and anxiety have been very, very clearly associated. We're talking 30 plus years of research to show poor attachment and true delays in infant development and then later child behavioral problems. In very serious cases, and these are extremely rare, they are the ones that you hear about the news. There are cases of maternal suicide and maternal infanticide. And while maternal suicide is something that's very rare, in Canada, in the UK, in the US, maternal suicide is one of the most common causes of maternal mortality, because our maternal mortality rates are actually quite low, which is a good thing, but it's these indirect causes like issues related to mental health that are driving up and are responsible for a substantial proportion of our maternal mortality rates. It's so important to treat maternal mental health issues early, because first of all, the sooner we catch them, the easier they are to treat, right? When the brain is left exposed to untreated depression and anxiety, it can actually be more difficult and take much longer to get somebody better. And also, with respect to child development, the earlier we get to someone, then the less chance that they're going to go on to a negative trajectory. And there was some really important research done in the US looking at maternal depression treatment and child behavioral problems of school-age kids. And the treatment of maternal depression, that alone, the remission of maternal depression improved children's behavior in school-age kids over the course of, a follow-up period of a year. So treatment at any point in time can have significant impact. We'd rather do it as early as possible. And this is just a slide to say that in the UK, the London School of Economics estimated the long-term toll that these kinds of illnesses can take. So this is just a slide to convince you that this is not a minor perinatal issue. As I said, though, most illnesses, mental illnesses that occur during pregnancy and postpartum are treatable. everyone requires support, everyone requires education, and that includes, in this time when we're treating the family, that doesn't just include the patient alone, it includes also the patient's family and other support systems. In general, I like this model because it's quite clear that when symptoms are mild, women can benefit quite a lot from what's called, in the UK, they call them low-intensity interventions. So interventions, for example, such as peer support that wouldn't require a healthcare provider, supportive interventions like support groups in the community, and our Healthy Babies, Healthy Children here in Ontario runs support groups throughout the province. These are nurse-run and nurse-led. And so in so many respects, we can actually be treating mild perinatal mental disorders before we even hit the sort of hospital or physician healthcare system, and we really should be. We should be matching need to care and have it be a much more natural part of our pathways of support for women. In some ways, some of these interventions don't even need to be conceptualized that way. However, once someone is having symptoms that are really affecting their function, that are causing a lot of distress, that's when we're getting into thinking about psychological services. So that would mean talk therapy with some sort of qualified provider who had training in these issues. Once someone, either if they have very severe illness that's presenting or if they're not getting better with psychotherapy or talk therapy alone, that's when we would start to be talking about other interventions, biological or somatic interventions, for example, antidepressant medications. So we have all of these treatments. We say that we can treat people effectively, especially if we meet them at the right level of care. Unfortunately, it's very clear that only 1 in 5 women who suffer from a perinatal mental health problem receive treatment that's adequate to remit their symptoms. How many people are surprised to hear that? Nobody's surprised to hear that. What would we think if we said that 1 in 5 women were not receiving treatment for preeclampsia? Would we be okay with that? No. So we shouldn't be okay with this either. I don't think anyone here is. And it's really not uncommon in my clinic to hear stories like, I really thought that this was a time that we were supposed to be happy. I feel so ashamed. I don't know why I feel this way. I feel disconnected with my baby. I didn't want to tell anybody. I've just been trying to push through. I just felt like if I could try just a little bit harder. I told my doctor about it. My doctor said it would probably pass. And everyone just said that, it just doesn't seem like anyone else is feeling this way. And they're 5, 6, 7 months postpartum, and they've been struggling the whole time. And we really have to do better at making sure that people don't have to suffer for this long because of the impact. So here are some of the barriers. So some of it is related to stigma, shame, lack of knowledge, maybe not knowing that there are effective treatments. But there are also some pretty significant issues like not having access to affordable specialized treatments. Although that's starting to change, it's actually quite difficult to get OHIP-covered psychotherapy in this province and in this country right now. So if we're saying that our most effective treatments are actually talk therapies, but the only thing that's covered by the provincial plans is going to the doctor who, like a family physician, wouldn't necessarily have that training or time to deliver it. And what do they have? So then are we giving out medication for people who really should be treated with psychological treatments just because we don't actually have the right tools? The other issues, though, which are very specific to perinatal are, wow, I've talked for 20 minutes already? Oh my goodness. That are specific to perinatal are things like trying to get your baby, to a set appointment time every week for example, having to be on transportation, on the subway, finding care for other children. And then the other big issues around acceptability and concerns about medication use during pregnancy and breastfeeding, and with the literature changing around that all the time, providers not having support and figuring out even how to advise women. So what I thought I would do in my last 5 minutes is just show you a little bit about what's going on in Ontario and the kinds of things that we're doing to try to address some of this, to give us some hope and to raise awareness about the kinds of things that we're doing. So Canadian context, Ontario, we've got about 14 million people, and we actually have health administrative data that's collected by the province that allows us to look at the kinds of services that people are using. And so this is something that I thought that this group might find interesting. This was a study that we did that looked at immigrant women and their use of health services. Now, in the Canadian Maternal Experiences Survey, it was shown that immigrant women actually report double the levels of postpartum depressive symptoms compared to non-immigrant women. And what you can see here is that actually, though, some immigrant women are using like half as likely to use mental health care services as Canadian-born women. So double the prevalence of the problem and half the service use. And as you can see, it differs across the board depending on where immigrant women are from, but still every group is lower than Canadian-born women. So that's telling us something about maybe something is going on in our healthcare system. This is about women who show up to the emergency department postpartum. The likelihood that you show up to the emergency department without having seen another healthcare provider first is higher for women essentially who have more residential instability, who have lower income, who have more material deprivation. Probably not surprised to hear that. And then in terms of suicide rates, we've actually published data to show that this is not evenly distributed throughout our province, that very large bar is our Northwest LHIN, where there is a high proportion of Indigenous women who are living. And so there's a lot that's spoken about, I know, about youth suicide, about suicide in general. And it's a sobering topic, but perinatal women are not exempt from this. Acceptability. I think I'll skip through this. I mean, essentially, acceptability, the issue is more than any other group, pregnant women don't want to take medications because they're afraid that it could harm their baby, and it's a big, big risk-benefit discussion. This is just a picture to show you some of the things that we're worried about. You know, women really, really don't know what to do about it. You know, 50% choose not to be treated with medication, and they're really, really confused about what to do, especially if they have severe illnesses where they've needed medication in the past. And so we're looking at a whole bunch of different solutions. One of these things is better access in hospital. One is better access out of hospital, and then trying to look at some novel treatment options. And so we've got, where I work, our clinic at the Reproductive Life Stages program at Women's College Hospital. We have, our CEO donated money to have a daycare on site so that women can actually come to their appointments, and especially if they have an older child, it's okay to have a baby in the room, but it's kind of hard to do therapy when you've got a 2-year-old like throwing books down and throwing toys across. So that's been amazing to have Stella's Playroom. We just have so many women who are so relieved of this. And then we have better access out of hospital. Has anyone here heard about Mother Matters? So Mother Matters is our online therapist-facilitated group for women. Any woman in Ontario can be part of it. Our therapists facilitate it, and it's not a live group. It has asynchronous posting. We tried to do live chats, and it was very interesting because women didn't want to do live chats because live chats was the problem, that you had to be somewhere at a certain time. And so they actually really appreciated that the asynchronous posting allowed them to not feel left out if they didn't make it to a conversation. So that's been a really neat initiative that we're hoping to expand. We're also involved in some trials to use essentially like Skype technology through the Ontario Medicine telemedicine network to be able to treat women in their homes. like telemedicine, how you do it right now, is often someone in a rural area, they have to go to their family doctor's office and go into this really weird room and get hooked up to this very big screen, and then that's how they could talk to a doctor or therapist who's many miles away. But there's actually the technology and the privacy now that we can do this direct to women's phones and direct to their homes, which is huge for this population. And so this is and we have an online decision tool as well for women who need to help make decisions about antidepressant use during pregnancy. And I put this up. Nisha is my research coordinator who works with us. And it was just so nice. We got so many emails like this for people just talking about how they just couldn't get access to this information any other way. And so I will leave you with a last piece of hope around new treatment options. Are there ways we can figure out who is going to get one of these illnesses and treat them or prevent this before it even happens? So we do have a study out where we're using an app to identify any woman who's ever had a baby and see if she's ever had postpartum depression. And then we're actually asking women if they would be willing to give genetic samples to help us then bring this into like a DNA database with a bunch of other countries around the world to see if we can figure out how to stop this before it even starts. So this is my plug for our app, if anyone is interested. And I think, I know that this was a little bit fast, but I just wanted to give you guys a sense of the kinds of things that we're trying to do to combat this really big access and integration problem for services that we have in Ontario. And I think I put up this slide about immigration. We don't have data around racialized women and their usage on a population level because those data aren't really collected. But I think it would be a really interesting conversation to talk about some of the barriers to service use and how some of these interventions could be adapted to make sure that they're inclusive for diverse populations. Okay.
Hello again. So we're going to actually hold questions and discussions for after Dr. Howlett's presentation. So Dr. Howlett is an associate professor and psychiatrist at the University of Toronto. He's also a co-founder of the Father's Mental Health Network and is the first to provide a father's mental health consultation and treatment program in Canada. Dr. Howlett?
All right, good afternoon. Thanks for the invitation to come and present at this conference. Usually you come to offer and share some information, but to no surprise you walk away perhaps having learned more than you've offered. And so it's great to be here. No conflicts of interest for me in this topic and in this presentation. Men and mental health, and specifically in this time frame in our lives, has also been understudied, and so we're trying to learn more about how men cope and deal with their health and mental health during this particular period. But I think so far we have sort of underscreened, underdiagnosed, and undertreated men at this time, and so we're keen to build services and close gaps for this population. I'm hoping in the next 20 minutes you'll walk away feeling more familiar with the concept of paternal perinatal depression. I appreciate the impact that this has on the family and the importance, therefore, of addressing this condition. And then be aware and thinking about strategies and interventions to treat and prevent paternal postpartum depression. So it's pretty simple. What we're talking about is depression in men who may be expectant fathers or fathers of infants up to the age of 1, that they're experiencing a major depressive episode. It could be their first episode or possibly a recurrent episode. And really what's specific about this is the time that it's happening. It's either during pregnancy or in the first year after birth. Men experience depression very similar to the way that women do, although men may express it differently. They may less identify with sadness and tears, perhaps more a bit with irritability and anger. But when you speak to them, they certainly can identify a number of other feelings, specifically during this time, feeling frustrated, powerless, helpless, and a sense of loneliness. I find quite a bit of cognitive symptom complaints in this group, feeling overwhelmed, confused, poor concentration and focus, a number of physical symptoms. And generally, people might think that when men are depressed, they may act out in some way or become angry or misuse substances. And while those things may occur, we certainly notice that prior to that, there's a decreased father involvement, more avoidance and isolation. If they're in the place where they're not feeling good about themselves and worried about making the situation worse or not being successful, they tend to avoid it. So again, some other kind of maladaptive coping strategies that we may assume or that occur within the male population. Again, being removed from home, perhaps working more excessively, or having even work-related problems. So how does it develop for men during this particular time frame? Well, like any health condition, it can be spontaneous. It can just develop without significant precipitating factors. Although that being said, there's usually a number of changes and things that are happening in a man's life as much as a woman's life during this particular time. How their partner, the mom, is doing physically and mentally can have a significant impact on dads. Issues around the pregnancy and birth complications or difficulties with the child's health, relationship stress, work-family conflict, and trying to achieve that balance that they think is important for them, keen to want to provide for their family that's been kind of bestowed upon them, but also wanting to be available and engaged and trying to manage that. Also, what we notice is that there's a real decrease in their ability to do the things that they were doing that might have been stress relievers or ways to kind of manage stress or cope, that they're less accessible to do that at this busy time. So generally, maybe up to 5% of men in their lifetime may experience depression, but during this particular time frame, that rate almost doubles to 8.5%. So it's twice that of the general adult prevalence rate, and it's pretty stable across this full perinatal period, with perhaps the highest point being in the 3 to 6 month postpartum phase. This is just a graph showing two different groups of fathers. The top solid line are men who become fathers at that 0 mark, but they don't live with the child or the child's mother. And this is sort of their kind of depression scores over their lifetime. Generally a group that's higher risk than resident fathers. But you can see in that dotted line, which represents men who live with the child and their partner, that after birth, their stress and depression score goes up until at least 5 years after the birth of their child. Particular risk factors that have been associated with paternal perinatal depression, the strongest one would be a partner, a mother who's experiencing postnatal depression, relationship dissatisfaction, their own personal history of a mood disorder, identifying themselves as having poor social support, really unexpected or negative experiences related to childbirth, so not wanting to have a child or having a child with health or developmental difficulties. And interestingly, a previous pregnancy loss has also been associated with depression in a father in a subsequent pregnancy or after a healthy childbirth. So this has great impact on the whole family, in particular for men. Depression makes them feel crappy about themselves, not just how they may be at home, but it tends to move over into other spheres in their life, including work, a loss of enjoyment, in particular with their child, decreased libido, relationship difficulties, poor self-care, increased risk of engaging in unhealthy behaviors, and the development in work and financial problems, which only can exacerbate how they may feel about themselves. In particular, when it comes to them and their relationship on their kid, we know a little bit about attachment. Of course, there's less studied with men than there is with a mother-child attachment, but we know some differences in their behaviors. They may speak more about themselves, may be more negative or critical in their communication, tend to be more withdrawn overall, less to engage in positive parenting behaviors, 4 times more likely to spank their child, and less likely to read to their 1-year-old on a consistent basis. Depression in men also has a great impact, unfortunately, on women in a number of ways. It's been shown to prolong the depression for moms, that their depression is more likely to be more severe, having a partner, the dad, when he's depressed. Mothers also complaining of lower relationship satisfaction and receiving less affection and support from their partners when they're depressed. In terms of the impact on children, you saw a little bit about this in the earlier presentation. But to categorize it, children, in these longitudinal studies, primarily done in the UK and Australia, but show that when they can identify dads who score high in depression screens during pregnancy and in the first couple of years, that they can follow that cohort longitudinally, and it's resulted in kids who are more likely to demonstrate internalizing behaviors, anxiety, avoidance, externalizing behaviors, being more oppositional, engaging more disturbance of conduct, kids actually being diagnosed with behavioral disorders. And certainly the relationship is direct between father depression and these outcomes, but certainly when there is mother depression and marital conflict, that's even more significant. So there's a real urgency to address this issue, much like I think there's an urgency to address perinatal mental health issues in women. It's a very stressful time, which is often unmanageable in these cases. Quite a bit of marital conflict. The mothers may likely be depressed when the dad is depressed. Caregivers burning out, and the reality is that both are trying to look after a child in what's such an important and critical time, and building their resiliency and protecting them from any sequelae. So in terms of screening, it's not a consistent thing that's done across various clinics or centers that are looking after women and families. The National Perinatal Association suggests and recommends screening dads at least twice during that first year of their child's life. When can we do it? Well, whenever really, I guess, the opportunity presents itself, and whether it's a general population and screening, in the context of perinatal care or pediatric care, or maybe even being more specialized and screening the fathers or the partners of women who are receiving specifically perinatal mental health care. We can screen by asking the mums, so by proxy we can ask them some questions to maybe get an idea of whether or not their partner may need further intervention. So again, just exploring how things are going with them and their partner, whether they have specific concerns about their partner, whether they're aware of their partner having a mental health issue in the past, or currently wondering whether that's the case at that time. Mothers can also complete a couple different questionnaires on behalf of their partner, whether it's the PHQ-2, which is a simple two-question questionnaire kind of framed in thinking about the dad, or the Edinburgh Postpartum Depression Scale, the partner version, which is framed the wording around how a mother might fill it out to thinking about her partner. Of course, screening fathers would be a great opportunity as well, and using various different measures that could be specific or general for depression. The Edinburgh Postpartum Depression, while developed for women, has been validated in men. And the scores are somewhat similar. If it's greater than 12, we're very concerned about the individual. If it's greater than 6, they shown to be at risk of developing depression and probably could benefit from some further assessment or intervention. And when the mums fill it out, if the score is greater than 5, it's worth finding a way to check in on dad. Not to say too much, but we're talking a lot about depression here, but various other mental health conditions can afflict a man and can become more apparent or more severe during this stressful time and this time of role transition. And so it's obviously worth thinking about anxiety disorders, substance use, and other conditions that may or may not be comorbid with depression. In terms of treatment goals, we're looking for the same things we would for any condition. We want to get rid of those symptoms. We want to restore their functioning. We want to, in this particular case, when we're working with men and dads, improve their sense of comfort and confidence in parenting. Want to think about their marital relationship and how to enhance that and help them feel more like they're functioning as a team. And of course, how to, explore, once they're well, keeping them well and preventing relapse. And I think it's just a great time to engage men in their health. Father's mental health is really, I think, a window to get men into the door to ask questions and reflect on how they're doing and feeling from various aspects of their health. And for them to think that, now that I'm a father and I have children and I want to be as healthy as I can for them, or I don't want them to experience anything that I've experienced, those motivations of, hey, I'm here for my family, I'll take that and we'll build on that and help them reflect and understand their own health and what they can do, whether it's smoking cessation, increased exercise, increased their social network. To begin that sort of treatment, I think it's really important about engaging dads, and that's a process that hopefully we'll continue to study and explore, not just in the physician's office, but in various other ways. But it's really thinking about, how the dad is experiencing this role transition, being a parent for themselves and being a partner in this co-parenting team, and letting them and their partners realize that this is an important subjective experience for them. And while we encourage and want them to be available for moms and supporting them, we can do that more effectively, I think, when we understand where dads are at. It's also, I think, good that, and I recognize that men want to be, I think like everyone, want to be self-sufficient and want to be able to do things on their own. And it's really framing these interventions as tools to get them back to feeling like they can do just that. Certainly there's some protective factors that we explore and try to develop further in terms of how they are engaging in their community, the sense of their relationship with their partner and their own family, how they communicate their feelings, and how they are as parents, and particularly with reflective functioning. Again, just sort of emphasizing different things that help them bring in their psychological wellness into their parenting, and the unique things that they themselves can offer in child development. The treatment, if in the case of paternal perinatal depression, I think the general treatment for depression in adults applies. We don't have the complication of the pregnancy or breastfeeding to make it more complicated in terms of medication. That being said, fathers who have been studied, prefer psychotherapeutic interventions over medication. So we can apply general guidelines and evidence-based treatment for dads. And we also kind of look to our colleagues in the maternal mental health to see what they're doing and to replicate some of that. As Dr. Frigod said, psychoeducation is an important piece to this intervention for dads, especially those suffering from adjustment disorder or mild depression. For psychotherapy, again, manualized, evidence-based treatments are also effective. And then with medication, various interventions that we could speak more to in the question and answer if the questions come up around that. Things that do come out of the literature to encourage those who are in this healthcare area around how to be more father inclusive. Some of these suggestions come up, such as having more men involved in the process, just more training and education around father-inclusive practice, and just meeting those needs of dads who may be working and have it difficult to attend outside of the working hours, and just to have a father or a male-friendly setting to welcome them. So I'll leave it at that. Thank you.
All right, thank you, Dr. Howlett. So we're going to open up the floor for questions or comments for about 10 minutes or so feel free to come up to the mics, and I will Kanye you if you go over time. Okay, all right, I'm watching you.
I didn't catch your name, actually. What was your
My name?
Yes.
Yeah, Andrew.
Andrew?
Yeah.
I was wondering, what effect has this research done on men knowing this exists, even if maybe their child's 13 or 14, they realized in hindsight that's what was happening?
Yeah, in terms of, I guess, coming to terms with the fact that they may have been struggling with these issues, earlier in their child's life. Is that the impact of that? Yeah, I'm not sure of there isn't a kind of great research around kind of men reflecting on their experience of being depressed or having a mental health condition for a long period of time, and perhaps not becoming aware of that until later on, after much years into their child's development. So don't know the kind of clear answer to that. That being said, I think there's, kind of on the flip side, I guess, a real motivation for men to want to, participate in this intervention sort of early on. I've had the opportunity to meet some, men either in my work in child psychiatry or on the occasion that I'm referred to male who may have children that aren't in sort of this perinatal mindset. It's clear that usually is that they've had some experience of this sort of thing, in the past, and I think it's there may be some kind of grief and disappointment and various mixed feelings, around that, and sort of identify and address, and of course, try to provide some comfort in that situation, but really, focus again on the here and now, and the opportunities of what can be done, moving forward for themselves, and their family. Mm-hmm.
Thank you.
It's making me think of the grandmothers I've had in my office who say, oh my God, this happened to me and nobody knew what it was. And I'm wondering whether there's been maybe a bit of a zeitgeist that for fathers, like we're not there yet, but maybe because of the work that you're doing, the next generation will be there.
Hi. Can you speak a little bit to just when you're working with mothers specifically on the kind of culturally relevant leanings that you sometimes take? You had mentioned, the reasons why women don't access, and I know from a Black woman perspective, a lot of times we don't speak up because there's racial biases against us as Black women, as Black mothers, and there's a fear of if we say, I'm going to harm my child, then CAS is going to come and collect, because we do know that the rates of Black kids in the CAS system is really high, and they're a lot quicker to snatch our kids. So if you can kind of speak to how you try to circumvent that fear from racialized mothers.
Sure. I mean, maybe I can start by speaking to that. And I mean, there was recently a case in the U.S. where a mother spoke out and ended up getting called by police and taken, and then didn't even get any treatment, and there's a whole thing. I mean, I think all of this I think what you are speaking about is not even necessarily only happening in mental health. It's unfortunately happening everywhere. I think part of the way to target that is we really try, even in our own educational materials, to be really clear about being non-judgmental, about trying to educate patients, providers around what is an intrusive thought, like an anxious thought that something bad's going to happen to your baby does not mean you intend to do something to your baby. But one of the things that we wonder about with like virtual care or with something like the Mother Matters intervention is that a way for people to have just a little more of a feeling of anonymity and still be able to get help, right? And then maybe that's a better door. Maybe that's a better door into the system, right? I mean, I think we're talking about these like double jeopardy and layers of intersectionality on the bias, right? And I don't think that there are easy answers. I think just more and more and more education that we can provide so that people understand what women are expressing when they're expressing distress. I think also speaking to what you're saying, though, is that people who are from different cultures may also have different ways of expressing distress, right? And so that's, again, something, to have cultural competency, or to at least, like, sometimes, in my line of work, someone will say something and I'll think, I think I don't get it. Like, I don't get what this means, what they're saying. And so you have to help providers be willing to say, you know what, I'm feeling kind of culturally incompetent right now. Like, let's just explore this and not make assumptions. And so that's the kind of education that I think we need to weave into our work. Like, just from like an immigration perspective, even over 25% of the kids born in Ontario every year are born to women who were not born in Canada, right? So like, that's not even talking about race and culture of people who are from here, right? So I don't know if that's helpful.
Well, I've had the experience that it's very difficult to access psychological services, and especially when you're depressed, it's hard to do anything, let alone navigate a very complex system that puts up many barriers, I feel like. And then on top of that, for men, I think there's a cultural difficulties in even asking for help. So, like, is there anything being done to address all of these barriers to getting psychological services?
So, I mean, the short answer is yes, but not enough. I think, as I mentioned in my talk, we're doing a bunch of different things to try and increase psychological services. Dr. Howlett and one of our therapists we call it a dual entry postpartum depression group. So either partner or both could be depressed coming in, and they run it like in the early evening to increase accessibility. I think, honestly, probably the largest problem in this province is that the first line treatments, which are psychotherapies, they're not covered by OHIP unless you get them from a physician. And it's not like psychotherapy is a procedure that you can make quicker. Like, you have to have someone in the room for a period of time. You can't, if somebody, yes, there are sort of these more short-term treatments. The truth is, shorter-term treatments work for people who have milder illnesses, right? And so it's really about matching level of need to level of care. And the Ontario government is committing funds to some more OHIP-based psychological services, and they're going to try to use the model that was put in the UK called IAPT, or Increasing Access to Psychological Treatments, which was an idea of implementing the model in a way that you would actually get kind of stepped care, like matching people to the right level of service, actually measuring and just trying to improve our capacity in the most efficient way possible. So it's not an easy answer. A lot of the work we're doing with virtual care is trying to circumvent the barriers, but the truth is, if I have like a really highly trained social work therapist who's working an 8-hour day, well, we try to do as much group work as we can, but she can see 8 patients each for an hour. Like, does it benefit anybody if she sees 16 for a half an hour each? Like, there's an HR issue, and we're talking about, perinatal mental illness. We're talking about like 20% of people. So 140,000 births in Ontario every year. So that means 28,000 women could use some psychotherapy. Like, those are massive numbers, and we need to figure out a way to do it efficiently, but it can't be an assembly line. And I think we're still struggling with that, unfortunately. I hope that's a reasonable answer. I don't have a better one.
Definitely.
Do you have anything to add to that?
No, I think I've been very curious to find ways to just engage men in this in the perinatal time frame, around getting them thinking about themselves, their health, their role with their partner, just in general speaking, and certainly for those who are increased risk of experiencing depression. And there are different things that are happening in pockets, different websites being developed to help support different populations, and we wish we were here 10 years ahead of kind of where we're at right now, but we realize that the accessibility and the navigation through the system is certainly challenging, but hoping to expand our partnerships with Toronto Public Health and things like that, so these interventions can be done more in the community than in tertiary care centers. Mm-hmm.
Thank you.
Similar to the other questions, I'm wondering, given all the research that you guys are doing, are you able to do, or are you doing research on specific cultural groups and how support groups or individual therapy might or might not work, or looking at how to target or increase accessibility of specific cultural populations? Have you guys been doing anything like that? And also, from the healthcare provider perspective, is there any discussion about increasing representation from actual people from marginalized groups?
Two excellent questions. Do you want to start? Do you want me to start?
Go ahead.
Go ahead? Okay. So, why don't I answer the second question first? So, the University of Toronto Faculty of Medicine has acknowledged and is going through a strategic planning process that the level of diversity that the current medical profession has does not reflect the level of diversity in our population. And that part of the planning is, and they've already done quite a bit of planning, but part of the planning is around how do we ensure not only diversity, but of course diversity is one thing, you can give people an invite to the party, but you have to have inclusivity, right? You gotta ask them to dance. And we have to consider equity and equitable processes to make sure that people who are from diverse backgrounds, who may not all start with the same level of advantage, are appropriately advantaged by the processes that are in place. And so the Department of Psychiatry at the university is also committed to addressing this, and it's complicated and it's slow, but I think that there is really a true acknowledgement and commitment to realizing that in order to meet the health needs of a diverse population, we ourselves would, that there's lots in the business world, the more diverse a unit you have, the better outcomes you have, and that's probably similar here. With respect to the research that we're doing, we try very hard to take a cultural lens to any work that we're doing. I'll give you an example. I had a fellow who was here for 3 years from India when we were developing our patient decision tool. And so she was looking at women from South Asian origin and around their use of the tool. And it has led to this whole sort of developing program research around that actually there wasn't a lot of interest in using that online tool because you had to take a few steps back, and really there was much more interest in the idea of actually focusing on community-based education around what on earth like a postpartum mental illness would look like. And so it was really amazing to see how this whole intent of what her project was going to be, let's make a, so innocently, like, let's make sure that our decision tool is culturally acceptable. We actually had to spin on our heels and say, well, wait a minute, like, this isn't, like, sure, we can make this and we can sort of force it and say, well, this is culturally acceptable. But when we actually went to the people, they said, no, we don't, like, actually, can you make us something else? And so that's what she's been working on. And I think we need to be open-minded like that, right? Like if we just come from like a top, you don't do design by coming and saying this is how it's going to be and then have no flexibility, because then nobody's going to use your design. So, that kind of stuff's in progress, but that's the sort of lens and flexibility that we're trying to have as we move forward.
Yeah, I would say that I think clinically where the Father's Mental Health Service has evolved at this point, and doing this for a couple of years, is around is seeing men who are often referred because their partner is receiving some form of mental health support. So it's certainly a family where it feels like there's a lot of risk and concern, because you could be having two parents who are suffering from psychiatric conditions at the same time. But I'm also mindful that that the women who are receiving that support, like in Dr. Vigod's presentation, may not be a great representation of the diversity or certainly the women in need. So we are limited by that. And so while we're trying to make it easy for dads to get to us by just knowing about the clinic, they have an advantage, I guess, in hearing about it through their partners being involved, and then we see the demographic disrepresentation around the different populations here.
Hi. So I live with a registered psychotherapist, and I'm currently accessing my own psychotherapy for prenatal anxiety. And I find that there's no real specific education for these people in terms of these birth parent mental health issues. And I don't know if that's just my experience or if that's really what it's like. I'm wondering if you can speak to that, if that's changing.
I didn't hear the first part of your
It's just
question.
that I'm finding that there's no mental health or birth parent mental health specific education for psychotherapists and social workers, and at least that's my experience of it, that I have to ask my therapist about grieving my miscarriage and, you know, these certain specifics that are related to the prenatal and postpartum depression that I didn't think that I would have to do the teaching on.
Mm-hmm.
So I'm wondering whether the education is there, is it changing? Are we all supposed to just fit into this whole of the training that's very generalized?
Oh, you mean within like psychotherapy training itself? Yeah, there are a bunch of organizations that do quite specific perinatal mental health training.
Like schools?
Like Postpartum Support International runs like webinars and conferences to do training. You know, there are various, like Mount Sinai Hospital here runs a specific perinatal training. There are perinatal adaptations of certain psychotherapy models, like interpersonal therapy, IPT. There are perinatal aspects of it. CBT also around anxiety. I mean, I think part of what you're experiencing is that it's not like there's, we talk about this often in psychiatry. It's like there's child psychiatry, and it's actually a specialty that you can get a certificate for. There's geriatric psychiatry, there's forensic psychiatry. You can get certificates for those things. You can't get like a certificate for women's mental health or perinatal mental health, although there are more like postdoctoral fellowship programs that are being put into place specifically for that. But you're right, it doesn't have. It's not like an official specialty recognition. I mean, I think we probably function with informal networks, right? Like of private therapists who we know in the community who have a lot of experience in this area.
So the education's not really geared towards that in any specific way right now.
You mean like if someone went, for example, to do an MSW, or if someone, I think they would have to seek out additional training in this more specialized area. Yeah. But there are training programs available to do that. For father's mental health, I don't think there are training programs for that yet. I mean, that's another thing to think about, right?
Yeah. If you were to recommend a website because if somebody's depressed, they're at home, they're not wanting to go out, so what would be a good resource? And my other question is postpartum depression, postpartum psychosis. I see a lot of women confusing the two and thinking that depression means psychosis, and that they will be a harm to themselves or their babies. So that's a real block in terms of anybody putting a hand up and saying, oh, actually, I'm having difficulty here.
Well, I would draw people, I mean, there are various websites. I mean, we have one, Mount Sinai has one, but Postpartum Support International really has a nice website, nice educational website that I would direct people to. And then how Postpartum Support International works is they actually, they then have regional offices. So if someone were to contact them and then want assistance in regional areas, I think that's probably, if I had to just name one website, I would say that would be a really good one to direct people to. You know, the postpartum depression psychosis issue relates to something else that came up before, this concept, this barrier to people seeking help because they're afraid that they're going to be involuntarily hospitalized and their child is going to be taken away from them. And it's so hard to see that because postpartum psychosis happens in about 1 in 1,000 births, right? And someone with postpartum psychosis is usually extremely confused, out of touch with reality. I mean, it's not even, like, I think most people would realize, for example, that schizophrenia is different than depression and anxiety. So it seems odd that they wouldn't understand that postpartum psychosis is different from depression and anxiety. But I mean, it's kind of like a similar distinction. But, you know, when you have a baby and it's the thing you love most in the world, it can be really, really scary. I think all we can do is continue to educate people that even when they're having intrusive thoughts, people, providers, you know, to know the difference. But I definitely still do see women in my office who took a long time to come because that's what they were afraid of. Yeah.
All right, so I think it looks like that's it for questions. All right, so thank you all for hanging in there. I know it's getting late. We're almost at the finish line, and I know it's been a long day, so we definitely appreciate you staying. Thank you, Dr. Howlett and Dr. Vigod. Okay, I almost got it. Thank you very much for your presentations and for leading the Q&A section of today's section. So last but not least, we have Brandon Hay. Brandon Hay is a TEDx Toronto speaker. He's also founded the Black Daddies Club back in 2007, and it's actually still going strong. And it currently counts about 800 members. So Brandon will be speaking today about fatherhood for Black men. Please welcome Brandon to the stage.
Good evening. So I recognize, so first of all, I'd like to thank the organizing committee for inviting me here to bring in the narrative of Black fathers in Toronto into the space. And also thank you guys for just sticking around. I recognize that I'm the last person standing between you getting home to your families, as well as being the rush hour, so I'm mindful of that, yeah? So before I begin, I'll just say two reasons of why I started the Black Daddies Club. And I'll just bring up my notes, which I'll be going to every now and then. But the first, I live in the Malvern area out in the east. And the first was when I had my first son, Tristan, in 2001. And I went to and this is before Taibu was in that area. But I went to a family resource center in the area. I heard that they had like a really good moms program. So I got dressed up, put on my khakis, my blue shirt. And I remember going to, speaking to the secretary and asking her, you know what, I've heard about you guys having this program for moms. Where can I find, point me in the direction for programs for Black fathers or fathers. And she looked at me confused, and she said, listen, we have programs for moms, grandparents, guardians, but nothing for fathers, not to mention Black fathers. And I remember leaving that family resources center that day and feeling discouraged, and feeling that my role as a father is not important. And flip that with, when I looked at Google and typed in Black fathers, what I would find was negative barrage of repeat of saying Black fathers are not anything. I heard some babies that I want to swear in this situation. The second piece, or the second reason why I started the club, which I think is more important in terms of bringing in race, was prior to 2007. I remember going to the Don jail to go visit my cousin who was inside. And I remember walking towards in the visiting area. And as I sat down, I remember the first time that I was actually in that same prison, which was to see his father, my uncle. And his father was deported. And it talked about the cycle. And I remember leaving that session, or leaving my visit, and said I had to, because before that I thought about this idea of doing a dad's group, but after that, I was very confident that it was important that I put black in front of it, because then I'm able to speak about issues that affect me directly, affect my community, that I can take up space in. So the agenda is sort of like, here it is, I won't read it off. I will be bringing in a research project that we did with the City of Toronto, OISE, and York University to kind of have a conversation today. So I'm the founder of the Black Daddies Club in 2007. My day job is I work for a social enterprise called Building Up. I'm a father of 3 boys, Tristan, Julian, and Elijah. I have a graduate degree from York and a certification from Schulich in social enterprise. I developed a curriculum, co-developed a curriculum for the Black Love Matters course at York University in the environmental studies faculty. You guys can read it. Yeah. So, what is the Black Daddies Club? So the first piece is we're creating space. We're creating spaces for black fathers to talk about our challenges, as well as look at strategies and create our own strategies that affect us directly. Work with the media, as well as to create our own media that depicts black fathers in a positive light. And then the last piece is around community-based education, which we'll talk a little bit about. So this talks about some of the programming that we do. This photo is from our annual family picnic that we keep. And the idea is that, I was talking to the doctor early on, he asked me the question, which I get a lot, where are you guys based? And we move around the city. And I think the biggest difference, I think working with black fathers, and maybe it's just fathers in general, the doctor, you probably speak to that more, but I know with black fathers is that, we have to go where they're at. It's not this idea that you build a program and then folks are gonna come. So this is when we started, we went to the barbershops, right? And there was another great program in the community called More Than Haircut, which I was a facilitator, a part of some years back. And I think that model is like choosing spaces where black fathers feel comfortable and they can speak and using their slangs and not feel ostracized and feel like this is home. And in the barbershops, if you've ever been in a black barbershop, this is where we're talking about from politics to relationship. So having conversations in these kind of settings makes sense. So I'll be using the themes from the Gathering Our Voice research project. The lead researchers was Dr. Lance McCready from OISE, Dr. Carl James from York, and it was funded through the City of Toronto. And I'm also using the images, some beautiful images by a dope friend and a brother named Jun Lee, did a project called the Black Fatherhood Project. So some of the themes that came up was this piece around role modeling. So black fathers talking about it's difficult to do this thing called fatherhood if you don't have a relationship with your own dad. So how do I know how to navigate this thing? So you're learning on the fly. The other pieces are on black fathers in the media. So I think this is really important because I think if you're hearing, especially if you're a young black man, or even a young black woman, if you're hearing this constant narrative that black men are not existent, or black fathers aren't there, you start to believe it. Believe it or not, right? And it becomes normalized. So what we're trying to do is to break that up. And going back to this idea of black fathers as role models, in the flip, black men were saying that there was an importance of not repeating. I remember one dad saying, I'm gonna do what my dad didn't do, basically. There was this consistent piece around black fathers being seen as providers. And we also see in the context of Toronto, where black men have one of the highest rate of unemployment when we start bringing stuff around having a higher propensity to get charged or having a criminal record. And then the last piece is the importance black fathers saw of being present. So we're going to talk about a bit around the challenges that were identified by some of these men. So the other thing that I want to make mention in terms of how we designed the research project was we moved around, we broke the city up into quadrants, and it's almost like a tour around the Greater Toronto area, where we went to different areas to make sure that we're getting as many different voices from different geographic areas. Yeah. So in terms of the family courts, and it's not just family courts, I would say family courts as well as the criminal justice system. So we talked about carding. There was an article by Desmond Cole. It wasn't an article, but it was an article that I think it was, I can't remember what publication, but he mentioned the story of driving with his dad and his family members and being pulled over because his cousin who was visiting threw a garbage wrapper out. And he talked about how he saw his dad, who was usually this powerful man, sort of just whimper down. And black men talked about this idea that, not being able to protect their kids. So family courts, I remember one father also mentioned he had dreads and talked that his lawyer told him that he should cut his dreads off if he wanted to stand a chance in the court system. Employment challenges. Research shows that black men in Canada is the only race that by marrying, you're not necessarily, the household is not being better off. I'm not sure that makes sense, basically, right? Educational attainment. So we see the prison to pipeline situation. As a father of 3 boys, this is something that concerns me. So I saw with my own 3 boys, there's that moment where my kids were cute, my boys were cute, and then they get into adolescent, and then they start to look like if their teachers is not culturally sensitive or has that experience, these young boys start to look like the villains that you see on CP24. So very quickly, these cute boys who are just acting like boys then get, reprimanded for just developing. And then the big piece was, black men talked about interaction with their children's school. So I heard some speakers talk early on. So this idea that, when stuff happens, the fathers are never contacted, even though their information is given, they're not a part of that dialogue, basically. And then the last piece is a lack of community space for black men to share, which is what I'll kind of focus on for the rest. So in the past 10 years, outside of Black Daddies Club, I've worked with fathers with Jesse's or June Caldwood Center, more than Macaulay, as well as Yorktown Family Services. And there's this theme. So when I did my master's, I focused on love, black love, and self-love within black masculinities in Toronto. So I brought this question a lot in my conversation with the men. And there was this interesting piece around love versus indebtedness. And these men talked about their relationship with their partners as well as their mothers. So talking about, not sure if it was love is what they felt or just feeling that they're indebted. So meaning that one man talked about when, if they go to get McDonald's, for example, his wife has to pay for the kids, but also pay for him as well. So there's this idea that he feels like he's indebted, he owes her something, that he has to be able to, he feels like one of the kids, he feels like a dependent versus being a co-parent. So I thought that was really interesting in this idea of love, that these men feeling their self-worth was also impacted. So some of the opportunities that I think are here for Black fathers is creating spaces for us to talk about issues that's happening within the community, creating a media campaign, and I think creating policy. So a few folks talked about the Anti-Black Racism Directorate. I think these are steps in the right direction. But let's not get it twisted, right? Like this liberation work has been happening from before the time of Batsy to current time with Black Lives Matter Toronto. So I think there has to be a vigilance that we can't just depend on the government. Like a lot of the work has to happen with community, but I think there has to be partnerships, right? And I think pieces around hiring, like having more equitable hiring practices, so that these fathers can actually take part in the co-rearing of their children. So I'll be talking a bit about what have Black Daddies Club been doing in the past 10 years in terms of creating spaces for Black fathers and their families. And these look very differently, right? So we had the Family and Friends Picnic, which is ranged from doing it in Orono to Scarborough. And the idea behind this is for it to be intergenerational. So you see grandparents to grandkids and everyone in between. So this speaks to this idea that it's a village that's raising a family. And also, we want to create spaces where the entire family can come out, not just Black fathers and their kids. Another program we have is Daddies and Me, which is a partnership with Kids Upfront Toronto. I'm not sure who knows, but Kids Upfront Toronto, they donate tickets to different organizations. And what this offered was recognizing that fathers that we're talking about, like when we went to the barbershops, dads were saying that, we want to spend time with our kids, we want to go to Raptors game, yada, 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 but we don't have the funds to do that. So partnering with Kids Upfront, they're able to donate tickets to us. What happens, it's sort of like, you see a slew of dads come into a space with their children. And what happens is it's community building. So if I have to go or take one of my kids to the washroom, there's a dad who's sort of like watching my kids and vice versa. And what happens is that you see kids are networking amongst themselves, the fathers are networking. When I'm on road with my kids would be like, that's Uncle so-and-so and so forth, right? So again, this idea of communities taking place. And then we have the football scrimmage, which again, it's sort of fathers, some fathers are going to engage in dialogue, and then some fathers, if I get my kid for 1 week or, on the weekends, I don't necessarily want to have him or her like in a space. I want to be out doing something fun. So it's also like looking at different ways of engaging these men. We do the family hikes, and the idea behind the family hikes was, being Jamaican myself, was my kids were, and still are, hooked on computer games, right? So for me, it was about having them disconnect from the video games and have them reconnect with the land, basically. And again, this idea of kids are networking with each other, the parents are doing so, and we're just getting out in nature, basically. So we talked a bit about the barbershop sessions, and this has been one of our consistent pieces, where you see there's a mix. So sometimes we have food that's there. Sometimes folks will bring alcohol into some of these spaces, and it's more or less for folks to it's us claiming the space, right? So we have these taboo discussions, ranging from monogamy to homophobia. This was from the monogamy discussion in 2008. And again, it's looking at different ways of engaging Black fathers as well as the Black community in Toronto. So last year was our 10th year anniversary, which we did a 2-year initiative called Black Love Matters, the on-conference. And the first part was the breaking bread discussions, which Kyla on the right or your left is sort of engaging in conversation. So what we're doing, we're going into different communities across the GTA and having this conversation about, you know, if we're supposed to do an on-conference around Blackness and Black love, what does that look like in the context of Toronto? So a few things that came out was that it should be intergenerational, looking at different ways, so engaging in arts, using different ways, so using food, you know, using different ways of engaging the community. And then from there, we did the course, we taught the course at York, and that was for 2 years. And the idea of the Black Love Matters on-conference course, it was in the planning department. It's a graduate planning program. And the reason, how we designed it was that it was partially graduate students and as well as community members who identified as Black, African, or Caribbean Canadians. And the idea behind it was when I was doing my master's, when I looked at the planning department, it was mostly white. And I know there were certain voices that they weren't going to engage with. So it's looking at planning through the social determinants of health lens. So each week, we're going into different communities. So here we're looking at the intersection of art and activism. We're at OCAD, where we have Honor Ford Smith, Dr. Honor Ford Smith, as well as Ajamu from England, who's a queer photographer, or a gay photographer. And each week was sort of a different theme. So what we're doing in 2018, I've been asked to curate a 2-day symposium, which is taking place next week. You guys are all invited. There's some flyers at the front. Please grab one on the way out. And it's called the Journey to Black Liberation Symposium at Harborfront Center. It is free for the most part, free and open to the public. It's taking place Friday, February 9th, and Saturday, February 10th. And the idea behind it, it's a series of cross-borders conversation with Black communities from Brazil, the United Kingdom, the United States, and of course in Canada. So some of the topic discussions will be Black masculinities, HIV, womanism and Black feminism. Rania, who spoke earlier, will also be on that plenary. And discussion around trans folks in the creation of the ballroom scene. And then we ended off with the Black Liberation Ball. And for folks who's familiar with the ballroom scene or have seen the film Paris is Burning, where voguing and it came from the ballroom scene, and the ballroom scene came from trans people, specifically trans women. And the idea of having a symposium and then a ball was last year as I was in New York for Black Pride. I was invited to go to check out, there was a symposium, and an elder in the community talked about, you know, when we're organizing conferences or symposiums, that we should include the boring part and the fun part. So the boring part are the plenaries, this setting where I'm speaking to you. I see a few folks yawning. And then you have the fun part, like the balls. Because of the ball, again, is recognizing that we have different ways of engaging and different ways of speaking. And the balls is a recognition that some folks are going to go to the ball that are not going to come to the plenary, and vice versa. And that there's a charge of $10 for that one as well. So for us, accessibility is super key. We made sure that the event, as much as possible, was free. We're bringing Laomi, which is an icon. She's an icon in the ballroom scene. She's also an athlete for Nike. And so if you type in Laomi Maldonado on when you get home or whatever, it should be a fun night. And just staying connected. This is the coordinates. And that is it. Thank you. Does anyone have any questions? I think folks are sort of spent. I'm going to be around. If folks have questions, like... Yeah, for sure. Okay, cool.
One, I just wanted to say I've heard about your organization over the last decade, and I think what you've done is so amazing and so needed out there. There's just not that level of visibility about how important Black fathers are. And I'm wondering how we can connect clients, especially in pregnancy, or if you've thought of having a Black daddy's prenatal group, basically.
I think great question, right? So I think...
I can help you do that, is what I'm trying to
Yeah, so I mean, as I had the conversation with Tanya early on in terms of looking at ways of partnering, right? And for when I started Black Daddies Club, it was father, but the long-term piece was around families. But I think one of the pieces I have to make mention is that Black Daddies Club is not funded. Everything that we've done is all volunteer-based. Right? So this work that I do is not work that is paying my bills. It's work that I feel is survival work. I have 3 kids, and it's sort of like creating spaces is for my own mental health, because I get as much from those groups as much as I give in. You know what I'm saying? With that being said, I'm definitely open to conversations. Yeah, but I think the piece is, Black fathers are also not the sexiest demographic for funding, right? So for us, it's like we also have to be really strategic in terms of having partnerships and how that we can make sure that we're doing this work in a meaningful way, in a relevant way, and being consistent, right? So I think, I'm mindful of, again, being reactionary and taking on too much. Because I've seen from a lot of the elders who did great community works and the family suffered, So I think there's also a constant balance and thought process around that. With that being said, thank you very much. Drive safe.
All right, everyone. Well, it's been a very long day, but I think that we can all say that we've gained a lot and we've learned a lot. I appreciate every single person who's been able to come, those who are streaming online, those who came earlier on and had to leave. I'd like to thank again all of our sponsors, and this is very important for me because all these people took the time to connect with us, providing with the funding and assistance needed to kind of have this day happen. Because without them, we couldn't have it for free, and we couldn't have all of you guys here today to kind of engage in that. So I'd like to really just thank again Ontario Trillium Foundation, the Student Commissions of Canada, the Black Physicians Association of Ontario. We had the president here earlier on, the UTGSU, Dalalana, IHPME, and the Black Public Health Students Collective, and the Black History Month Committee here at UHN. Throughout the month, they'll be doing other Black History Month celebrations as well and other sessions that you guys can join in as well. So again, thank you all for being here. Safe drive home. And again, let's continue on with this discussion, this dialogue. On our website, we hope to have the presentations, the YouTube videos from today that we've streamed, and other information and resources that people can connect with and use. The key piece of feedback I've been getting from all the people here is that they enjoyed the opportunity to network and have this dialogue and a space to have these conversations. So let's continue to do this, and hopefully this will be something that we can continue on in 2019. Thank you, everyone.